How are you today?
Good, how are you?
Good.
The wrap-up email, is that always supposed to come to our email after class? Or
It should, yes.
Yeah.
Are you not getting them?
No.
None of them?
The ones in the beginning when we told you, yeah, I got all them.
Okay.
But the last two, no.
All right. Let me send a message to Caitlin to look into that.
And then the other question I wanted to ask you, if you mail that, that paper in for the test, that one girl was saying you need that paper to bring in that day, but don't you just print what they send you in your email?
Right. They're going to send you a test admission letter.
Okay.
And even if you don't have it, they can look it up, like if you don't have a printer.
Okay.
Good morning.
Good morning.
Morning.
Good morning.
It's funny what you said last week with, well, the other day when you said about, signing up for the test and waiting because you think you need more practice. That was my same thought. Like, well, maybe I should wait until the class is done and then I have more time to study more so I know more, but not to do that.
That's what a lot of people, that's the thought process of a lot of people.
Yeah. Because with work and everything. But then I'm thinking when I do the tests, I do okay with that. I just need more skills. The skill part. And that's practice, right?
Yeah, it's just practice, but like I said, you guys are definitely way more prepared than you think you are. Sorry, I just need to get these loaded in here. Good morning.
I have a doctor's appointment today at like 1, so I'm going to
No problem. We're actually going to be ending the instruction early, probably around 12, and so that you guys have practice time at the end of class today. So during practice time, you can leave at any time. I mean, you can leave at any time, but it's easier during practice time.
Yeah.
So let me send Caitlin a message. Is anybody else having trouble getting your after class wrap up emails?
I am.
You're not getting them?
Mhm.
You are getting them or you're not?
I'm not.
Okay. Good morning.
Good morning.
Okay, Lucy, can you check your spam folder? Because you have Yahoo.
Yeah.
So can you check your spam folder for me? Because Yahoo's does block us. I know, Neve, you have Gmail, so it should go through. But can you just do me a favor and check your spam and promotions?
Okay.
I just asked Caitlin to check, but she said that the system is. It looks like the email system is operating right. So just check and see. If you don't see them in your email, your spam, let me know and I'll dive in a little bit deeper. All right. So it's 9 a.m. Let's get started. Hey, good morning. Good morning. 1 week left, guys. Isn't that crazy? This goes so fast. So fast. Okay. So I had a phone call this morning on my way in. Somebody wants to sign up for the class starting the next class we have starting. She's actually purchased her plane ticket to come to class. She's coming down from Washington, D.C. to attend class. So very interesting. I've had people that have come in from like Miami and Tallahassee, but usually within the state. She's going to be moving to Florida, but she's going to, that's just crazy. That's a commute. That's a commute. All right. So you guys had chapter 7. Any questions on chapter 7? Anything I can help explain to you? Oh, okay. I want to put a comment up here real quick that just came in. And Caitlin is stepped away for a second. So let me put this comment up. So this says, I passed my skills exam. Now I'm waiting for the written exam. Thank you for your videos. May God bless you. So congratulations to you. Great job. And again, this is somebody who is not sitting in this classroom. So how much more prepared are you going to be? So I also got a phone call yesterday. One of my previous students, let me just let her know. Got it.
One of my previous students passed the exam yesterday. So that's awesome. And then she referred her cousin to us. So her cousin's going to be taking the class as well. So another person from a previous class. So you guys are well prepared. You don't know it and you don't feel it yet, but you are. Okay, you are. All right. So chapter 7, let me go ahead and get your scores. What is going on here? Okay. All right, Rochelle, Neve, Shakima, 2, James, Vanessa, thank you, Christopher, Dwayne, Maya, thank you, Vita, thank you, Lucy, thank you, Asia, good morning, Shelby, Adam, thank you, Faith, thank you. Faith, do you have 1 through 6 for me? 1 for all of them. Got it. Very good. Okay. So remind me of your name. That's what I thought. Okay, I've got I have my finger there. You okay? Do you have 2 through 6 for me?
6, I didn't miss any.
Okay.
5, I didn't miss any.
Very good.
4, I missed 3.
Thank you.
3, I didn't miss any.
Okay.
And 2, I missed 1.
Very good. Okay. All right. Does anyone have any other questions for me before we get started? No? The reading going okay for you? I know it's kind of long, it's kind of boring, but it's information that you do need. If I stood up here and gave you, lectured you on everything that's in that book, we would be here for days. And it's stuff you can get on your own. Okay. All right. So, review. How do we know what to do with each patient? We follow the care plan, the whole care plan, and what does that mean to us? What does that mean? Can't change it. Yeah, even if you think your way is better, or circumstances change, or whatever the case may be, we can't change that care plan. And that's really important to know because there's going to be 1 or 2 questions on the written exam that's going to try to get you to change the care plan. It's going to give you information that is completely irrelevant. And it's going to try to get you to change that care plan. So be careful on that. That's why I spend a lot of time on this. But it's not just about the test. We have to understand this for a clinical setting as well. Okay? Really, really important. There was in one of the CNA groups this weekend, there was a issue with that. Somebody was complaining. A CNA was complaining that she got in trouble because she did something that wasn't on the care plan, but the patient needed it. And she couldn't understand why she was reprimanded. So there's a lot of CNAs out there because not everybody teaches this. Okay. A lot of people just teach the skills. And if you know the skills, but you don't know the background behind it, it's not going to be very effective. That's why I spend a lot of time on the care plan. So there's a lot of CNAs that you're going to work with that don't understand the importance of not changing anything, letting the nurse know. And you may come up against some opposition because of that, because they truly don't understand their role. Understand that you are the one that's covered in that situation. So unfortunately, there is some conflict out there sometimes. That's why I live stream this for free, because I don't think that a lack of funds should be an excuse for not understanding your role. That's why I started doing this. While we're doing those tasks, what should we be doing? What's half of our job? Observing. And what should we do with those observations? What if we don't think it's a big deal? What if we think it's just minor? Still report it, because we're not an effective judge of what's minor and what's not. We just don't have enough information behind us to make that determination. Remember, the smell of grape Kool-Aid actually means something. Okay. Every skill starts with an opening. What does every opening start with? A knock. How do we know we're with the right patient? Yeah, we can ask them their name, or we can say their name. Sure. Should we touch them to see their ID band? Why? Ah, very good. Good job. Good job. That was actually a question I got in one of my YouTube comments yesterday. What about, checking their ID band? Can't do that before your hands are washed. So just address them by name. Once we've addressed them by name, what do we have to tell them about us? Okay, name, title, and skill. Very good. Why do we have to tell them what we're doing? I mean, they're there. Why can't we just do everything we want to do to them? Yeah, we have to get consent. They're humans. They're humans. They have to give consent. And then once we get that consent, we can close that privacy curtain. Is that curtain clean? So what do you want to do after that? Wash your hands. Can you get all of your supplies before you do your opening? Why? Yeah, what if they say no? That's a great point. What if they say no? You've got all these supplies, and now we've got, well, what would we do? Can we just leave those supplies in the room for later? No, you have to get rid of all those supplies. So that's a huge waste of resources. But if we just take our supplies in, we've touched those supplies with dirty hands, and that is a cardinal sin. Good? Makes sense? Yeah, that's actually probably one of the most missed steps on the state exam. And I get why. I understand it. I do. Because supplies are a lot to remember. Let's think about partial bed bath, what we learned on Monday. Can anybody tell me some of the supplies we need for partial bed bath? Okay, how many washcloths? Let's start there. How many washcloths? 4. Yeah, 4. 4 or 5, but I show you with 4. Okay. So we need a basin too, something to hold the water. Okay. So we've got 4 washcloths in a basin. Soap, 2 towels, lotion. Barrier. We got to have something to put all that stuff on. Sure. What else? Gloves, because we're washing wet body openings. What else? A clean gown. And privacy blanket. Yeah, so a lot of supplies there, right? It took all of you to figure it all out. A lot of supplies there. Too bad this test isn't a group activity. I've always said that. I think it should be a group activity. So if we understand how many supplies that is, and during the test, you're going to be nervous, right? Your first action in your mind is, oh my gosh, I got to get all my supplies before I forget them. That is not a good strategy on the state exam, because you're touching those supplies before you've gotten permission and washed your hands. So that's not going to be viewed very well. Does that make sense? Okay. All right. Whoops. Let me go back here. How do we know when we need gloves? If we're going to touch body fluids, non-intact skin, and personal skin. Yeah, absolutely. What's the first thing those gloves should touch if we decide to wear them? For the test, should we just make it safe and wear gloves for everything? No, because that shows that we really don't understand gloves. Yeah. And then we want to remove those soiled gloves correctly by pinching up, pulling off, going under, pulling off. All right. Sometimes we need supplies. The supplies need a clean place to hang out. So we're going to use a barrier. A barrier provides clean area for our clean supplies. When should we go get the barrier? Before or after we get our supplies? Before. And that's so we don't hold those supplies up against our uniform because your uniform is not clean. Okay. Very good. Privacy blanket. Sometimes we need one, sometimes we don't. How do we know when we should use one? Uncovered or undressed. So do we take the sheet all the way off and then put the blanket on? No, because that exposes our patient. So we're going to put the blanket over the sheet and pull the sheet down. Very good. What should you not do to a privacy blanket? Shake it or snap it. Very good. And then if we're going to use it and we're wearing gloves, when should we remove that privacy blanket? Before or after we take our gloves off? Say it loud. After. Yep, after. Very good. Because you don't want those dirty gloves to touch that sheet that's going to go right up next to their face. Linen rules. These are all basically repeats of what we've learned so far. So what can't linens touch? Uniform or the floor. Yeah. Pick a word there. Absolutely. We have to have clean hands to get those linens. We don't want to snap or shake them. Those are all things that we've heard before. Clean rolls toward me, dirty rolls away. And what do we do with anything we don't use? Yeah, discard it. Absolutely. Then we have to keep our patient safe in bed. So where should the patient always be when they're in bed? In the middle of the bed, what we call the safe zone. Absolutely. Even if they're on their side, do they need to be in the middle? Okay. So when you end a skill, you're like, whoo, I got the skill done. I got through it. I'm still alive. Don't forget to stop and look at your patient because you're so focused on your steps that if you don't look at the patient, you may not realize they're too close to the edge of the bed if you've turned them on their side. So take a minute to stop and look at the person. Remember on the first day, I told you my hardest job, not teaching this. This is not hard. My hardest job is to get you to remember that the test is not about you. It's about the patient. So at the end of the skill, you should hear my voice in your head going, it's not about you, it's about the, and you stop and look at the care plan and the patient. Absolutely. Got it? If you do that, if you can focus on the patient rather than you and your steps, you are guaranteed to pass. Guaranteed. Okay? Focus on the patient. All right. And then when we turn a patient, we always turn them away from us so we remain behind the patient's behind. And remember, the patient must always be in the middle of the bed. No matter what position they're in, they have to be in the middle of the bed. Now, we do have some washing skills that we do, actually, quite a few washing skills. And there's some rules that go along with it. This washing skills, every single one of these actually counts big. So if you forget any of these, it's a big deficiency. Not enough to fail you on its own, but you put a couple of them together and they'll tip the scales. So even though there's a lot of steps here and they all kind of seem basic, understand they're not basic from the test point of view. Okay, what can we not put in our basin of water? Soap. And that's because we have to have water to rinse. That's right. When we're getting water, can we touch that faucet? No. And that seems like a very small detail, but it's a really big one. Because if we touch that faucet and we contaminate our hands, and then we're near wet body openings of the patient, that's a big issue. Make sense? Okay, so we're going to use a paper towel to turn that water on. What should the water feel like? Who else checks it? Patient. Whatever we wash, we whatever rinse we dry. We're going to use a special method when we're washing wet body openings. We learned this on Monday, and it's called the leaves method. And it's when we hold that washcloth with the free edges at the top, we wipe something and fold it over. So we use the leaves method for wet body openings. If the skin is intact, we don't need it. Just wet body openings. We're going to use that again today when we get into Peri-Care. Don't get your surface wet, whether it's the table, the floor, or the bed. In the test, if you're doing, let's just say a partial bed bath, okay? You're giving a partial bed bath on the mannequin and the sheet gets wet because you didn't wring your washcloths out good. You had some drippy wet washcloths. The sheet got wet. Can you pretend that the evaluator didn't see it? No, they saw it. They're looking for it, actually. They're looking. So if that sheet gets wet, don't ignore it. You must address it. Now, you're not going to have to change the sheet for the test. That's not on the care plan, but you're going to have to say, the sheet is wet, I would change it. You want to acknowledge it. Because if you don't acknowledge it, when you're out there working and nobody is watching what you're doing, that tells the evaluator you're going to leave a patient in a wet bed. How comfortable do you think that is for the patient? That's icky. Don't do that. So you must address it. Okay, don't think they didn't see it. Trust me, they see everything. All right, and then if we're going to put lotion on, what do we do before? What do we do after? Wipe it. Yeah, basins are all clean the same way. Rinse it, dry it, store it. We don't care how you do it. Just rinse it, dry it, store it. But when you go to open that drawer, your hands are not clean, and we're going to touch that drawer with clean hands later. So what do you think you need to open that drawer? Paper towel. All right, then we have shoe rules. If the patient's feet hit the floor, we got to talk about their shoes. Are slipper socks ever enough? No, do not walk your patient with slipper socks, please. There's an infection control aspect of that, along with, unfortunately, a sharps issue, right? People can injure themselves and may not even realize that they've injured. If we're going to use a gait belt, and the first skill we're going to learn today is going to use the gait belt as well. We learned a little bit about the gait belt on Monday. We're going to use it again. How do we know a gait belt is tight enough? 4 fingers. Don't be generous here, because do you remember when we stood the patient up, that belt was snug. I checked it with 4 fingers. You guys saw me. But what happened after that patient stood up? Yeah, we get skinnier when we stand up, and that belt got way looser. So if we're too generous here, if we don't make sure that belt is tight enough when they're sitting, when they stand up, that belt becomes so loose that if they start to fall, it's not going to be any help to us at all, because it's just they're going to fall right through it. So you want to make sure that your gait belt is snug enough. That's a safety step. So it counts really big. Before you stand somebody up, what position do their feet need to be in? Flat on the floor, and they may have to scoot forward in the chair a little bit to accomplish that if they got short legs like me. But make sure their feet are flat on the floor. Do you stand right in front of the patient when you lift them? No, you want to stand at that oblique angle when you lift them, and that keeps your back from accommodating all of that pressure. So once we get the patient standing, we have to ask them a question. What question are we asking? Yeah, are you dizzy? Absolutely. And before we stand them, we want to make them a partner, so we're going to count to 3. Also, when we sit them down, count to 3. I'm going to help you sit. 1, 2, 3. Everybody needs to be on the same page here, okay? When you remove a gait belt, how do you remove it? How do you remove a gait belt? Do you just slide it along the skin? No, because that can burn the skin. So you want to reach around or loop it over, but don't slide it against the skin. If we want somebody to sit down, they've got to know that chair is behind them. How do we know that they know the chair is there? Yep. Tell them back your legs up until you feel that chair. Absolutely. And then finally, every skill ends with a closing. Lots of C's here for the closing. What kind of environment does our patient need to be in? Clean and safe. And the bed needs to be in the lowest position to make it safe. Absolutely. We want to make sure the patient has something over them, whether it's a sheet or clothing. So we have to make sure that they're covered. And we need to ask them a question. What question are we asking? Yeah, are you comfortable? Absolutely. Are you comfortable? Part of comfort is emotional. So what can we offer them? A magazine. What do they need in their hand before we leave? The call light. And then should we leave the privacy curtain closed for everything? No. We want to open that privacy curtain. What if they ask for it to stay closed? What if they ask? I want that curtain closed. Just leave it closed. What would you do? Okay, that's right. That's an observation, isn't it? That's a change. Who needs to know about changes? The nurse, absolutely. You can leave it closed for them. Okay, no problem. And then just go let the nurse know, hey, Henry asked for the curtain to stay closed. And the nurse, if she's a good or he is a good nurse, will go in to figure out why. Do they have a headache? Are they tired? Did they not sleep well last night? What's going on? Why do we want that curtain closed? There's a story there. There's a story there. I enjoy creative writing. I write stories in my very limited spare time. And I always look at everything as a story. There's a story there. Everything that you notice about the patient is going to be a story. If they don't want to eat, there's a story there. So let's get to the story. What's the story that they're trying to tell us? Okay, good. Okay. And then once you've done all of that, you're going to go clean your hands and then chart if necessary. But once you chart, what do you need to do again? Clean your hands, because remember, our cardinal rule here is end skill with clean hands. All right, so you've mastered everything on the back wall. There's nothing new to learn. Nothing new to learn. So from this point, everything that we're going to learn is going to be some sort of a rehashing of the principles that we've already learned. So from now on, it is easy bill, smooth sailing. Okay, we're just going to reuse the principles that we've learned. So let's review some of the skills that we've learned so far. Let's talk about pulse. When we're taking a pulse, what needs to be supported? Yeah, the elbow always should be on the bed. The wrist can be supported. The arm is what I'm looking for here. The arm, we always support the arm. But yes, the elbow specifically always needs to be on the bed. And think about, so everybody raise your arm up just hold it up there for a little bit, right? It doesn't take long before that arm starts to get heavy. And right about now, you're probably feeling a little bit like, I want to move my arm. This feels awkward. How long was a minute when we took the pulse? A long time. Imagine trying to, now your arm's probably burning a little bit now. Imagine holding your arm out like this for a full minute. That is going to make these muscles engage. Engaged muscles need blood flow. So what is that going to do to your heart rate? Go ahead and put your arms down. What is it going to do to your heart? Yeah, it makes your heart beat faster because now there's a muscular demand for that blood flow. So if we have that arm just out in midair, what do you think that's going to do to our pulse rate? Makes it higher. That's right. It elevates it. So are we getting an accurate reading here? That's why the elbow needs to be supported. Good? Make sense? All right. Pulses are always reported over what time period? 1 minute. Doesn't mean we have to count for 1 minute. It just means that we have to report it over 1 minute. So how do we know which method to use? The shortcut method where we can count for 15 seconds and multiply that by 4, or counting for a full minute? How do we know which one? The care plan. So we're always going to follow that care plan. What is a normal pulse rate? 60 to 100. And when we're counting the pulse, what are we actually counting here? What are we counting? Are we just counting to 60? What are we counting? The thumps that you feel under your fingers, those are waves that are produced by the heart. So we're finding those thumps and we're going to count how many thumps. We're not just counting to 60. How many thumps? Good? Make sense? Okay. What area of our fingers do we want to use? The tips of our fingers. What finger can we not use? The thumb. And remember, the pulse is located at the top of the thumb side of the wrist at the bendy part, like right here where my thumb and wrist join, right there. Not way down here, way up here. Okay. How does the evaluator know when we start and stop? Yeah, when we tell them. Absolutely. Now, I bring that up because I just had an evaluator tell me about 2 weeks ago that she's seeing a lot more students come through that aren't announcing start and stop. They just start in their own head, they count, they stop in their own head, and then they write down a number. Well, the evaluator has to be able to count for the same amount of time that you count to judge your accuracy. So if you're not saying start and stop, they're going to make you redo that skill. You don't want to eat up your time doing that. Okay, good? Makes sense? And then anything we count, bless you, anything we count, what do we have to do? Chart it. Yeah, document it. Absolutely. Dressing a resident. How do we know how to dress and undress when they have a weak arm? What was the acronym I gave you? USA First. So what does USA First mean? Undress strong arm first. And then which arm do we dress first? The weak arm. When do we want to get the clothing? Before or after we undress them? Before, to minimize exposure. Do they get to choose their own clothing, or do we get to decide what they want to wear? They get to choose. Okay. And remember to maintain privacy. You are a stranger to them. You are in the room with them while you're dressing them. So keep them covered to the extent possible. Dignity and privacy are important topics, no matter what they tell you out there. Remember that this is a human, and not a lot of humans are comfortable completely disrobing in front of other humans they don't know. Make sense? Be careful with that. Anytime we lift, how do we lift? From above or below? Below, and we're always going to support at the joints when we lift. We don't want to overextend or force movement. And we want to adjust the clothing at the end of the skill. Everything goes in the hamper when we're done with it. Remember, clean our environment. And call light should be in which hand here? Stronger hand. Hand and nail care. Again, we've got that whole support thing going on. You're starting to see a trend here. Yeah, we give more support than, separated parents. Okay. So we want to support that wrist and arm at all times. We're going to soak the hand in water and then take it out to wash it. Where should we put that hand when we're washing it? On a towel. We're going to put the soap where? In the basin or on the washcloth? And when we're getting washcloths, remember, we got to wring them out really well. No drippy, wet washcloths. Whatever we wash, we rinse. Whatever rinse, we dry. And then we're going to clean under the nails. We're going to use an orange stick for that, but which end do I want to use? Yep, the slanted, beveled, curved end. And what should I do in between nails? Wipe it off. I'm going to file the rough edges with an emery board, but how do I file? One direction toward the middle. Very good. Very good. And then we apply lotion first, last. All right, making an occupied bed. This is simply changing the bottom sheet a half at a time. When you're doing this, there's a process we use. Clean rolls toward me, dirty rolls away. And what do we want to make sure is not under the patient after we make the bed? Yeah, anything. Yeah, cell phones, crumbs, earrings, hearing aids, dentures, whatever you got. But there's something else too that might be a little harder to avoid. Colitis one. Wrinkles. Yeah. What do we know about wrinkles? They can cause bed sores. Yeah, it's an additional area of pressure. So remember that we remain behind the patients behind. We want to make hospital corners to keep those corners of the sheet off the floor. Remember, nothing should touch the floor. But once we make those hospital corners, what do we need to do to the toes? Yeah, loosen it over the toes. Very good. And we're going to replace that pillowcase with the opening facing away from the door. So I know we go through all of these over and over again, right? And you're like, I got it. But I want you to remember that this repetition that we're doing is going to help you on the state exam. I can't tell you how many hundreds of students have come back to me and told me, I heard your voice in my head. I heard your voice when I was testing. And that's why I go through this. But remember, your flashcards have these on them. So you can go through and you've got access to all of this. Okay. It's also in your book as well. So when we're turning a patient onto their side and propping them there with pillows, we're always going to scoot them toward us before we turn them. Good? So if we're going to turn somebody that can't turn themselves, if they can turn themselves, we're going to let them. I'm not getting involved with that. But if they can't turn themselves, there's a process that we use. Furthest arm up, closest arm over, closest knee bent, furthest knee angled. If you do all 4 quadrants, up, over, bent, angled. Okay. Up, over, bent, angled. If you can remember that, then the turn, super easy. Then you're going to put a pillow behind their back and a roll, one between their legs, specifically between which joints? Knees and ankles. Yeah, knees and ankles. You want that pillow to pad between the knees and the ankles specifically, because you don't want those bony areas rubbing together, which can cause a sore. Okay, another pillow under that top arm to get it in a nice neutral position. And then we adjust the pillow under their head. So it should only be under their head and neck, not under their shoulder. Which hand does the call light go in? This one doesn't have a stronger or weaker, but it does have a top and a bottom. Bottom arm. Yeah, because you don't want that call light to go over the patient's neck, that cord. You guys remember me saying that? We don't want that cord over the patient's neck. We want it on the bed and in that bottom hand. Good? All right. Foot care, just like hand and nail care, only lower, no nails. So foot goes in the basin, take it out, put it on a towel to wash, put it back in the basin to rinse, take it out to dry. But why are we doing this? What's our whole purpose for doing foot care? Observing. Yeah. So during the test, what do you think you have to say? Yeah, I'm looking at the foot. Absolutely. I'm looking at this foot. All right. And we're going to lotion everywhere but between the toes. When we put the shoe and sock back on, we've got to make sure that sock doesn't have any Wrinkles, yeah. All right, mouth care. How do you brush teeth? Don't overthink this, guys. Don't overthink this. It's just mouth care, just brushing teeth. But what position does our patient need to be in? Yep, sitting upright. Absolutely. What do we want to do for that clothing to prevent toothpaste to getting on it? Put a towel, put something on there. Absolutely. What do we do with a toothbrush before we put toothpaste on it? We wet it. Absolutely. Should we use a ton of toothpaste here? No, little dab is fine. What areas are we brushing? Yeah, everything they got. Top, bottom, front, back, tongue. Absolutely. If you listen to the video, if you watch that video again, you'll actually hear me say that. I'm brushing the top on the back. I'm brushing the bottom on the back. I'm brushing the top on the front. I'm brushing the bottom of the. I talk about the quadrants. I say what I'm doing. Because when that toothbrush is in their mouth, the patient doesn't know where you're going. But the evaluator also doesn't know what you're brushing. So if you say it out loud, it does help. Okay. Patient has to be able to rinse and spit once, twice. What do you guys think? Many times as they need. Absolutely. And then after they spit, they're going to have stuff all over their face. What are you going to do about it? Don't forget. That step gets missed a lot because you are focused on your steps. Again, who should we be focused on? The patient. So don't leave that patient sitting there dripping toothpaste while you go clean your basin. That strangely gets missed a lot. All right. Respirations. What do we not want to tell them? Yeah, we're counting their respirations because they won't breathe right. Absolutely. They start breathing fast or they stop. Yeah, either way, not accurate. In and out counts as one whole cycle. So it doesn't matter whether you start on an inhale or an exhale, we're still going to count it. What is a normal respiration range? 12 to 20. So if you got 10, what would you do? If you got 22, what would you do? If you got 36, what would you do? Report it quickly. Report it quickly. Absolutely. And remember, respirations like pulse are always counted over, or always reported over a full minute. You can do the shortcut, 15 seconds, multiply that by 4. You can do that as long as the care plan doesn't specify 1 full minute. All right. Remember, again, you have to tell your evaluators when you're starting and stopping, so they're counting at the same time. And this is a counting skill, so we have to document. Range of motion. Why do we do it? Retain. So if the patient has pain, is that a good thing? No, that's not us. We're going to go below the pain for the next repetition. Flexion extension is an, abduction adduction is a, and rotation is around. Follow your recipe and your cake will come out just fine. Remember, there's 3 range of motion skills on the state exam. So your chances of getting range of motion, pretty good. But they're the easiest skills we do. All right. And denture care. Denture care has 2 parts. We're going to clean the dentures and the mouth. But what do we want to put in the sink when we're cleaning the dentures? Washcloth. Why? Yeah, absolutely. If they fall, we don't want them to break. What kind of water should we use? Cold water. Absolutely. And we're going to use a special denture brush to clean the dentures. It's double-sided. One side is small to get into the groove. The other side looks like a toothbrush to brush the teeth and the palate. When we're done brushing and rinsing, where do we put those dentures? In the cup. But what should we do with the cup before we put the dentures in? Yeah, rinse it out and fill it with water. Very good. Very good. And then what do we put under the cup when we store it? A paper towel. So denture care, we're going to clean the dentures, but what else do we have to clean? Yeah, the mouth the dentures came out of. So we're going to use regular mouth cleaning processes. Same skill. So this skill is actually kind of a 2-for-1 skill, right? We have mouth care, and then we have denture care with mouth care. So it's a longer skill. They give you more time to do it. At the end, we always make sure we leave our patient clean and safe on the closing, but for this one, they're going to have liquid dry. That's what we're looking for. Ambulate with a gait belt. We learned this on Monday. We're going to apply the gait belt while the patient is sitting or standing. Sitting, yeah. The fact that this has to be a checkpoint just blows my mind. Like, who is standing people up and then putting a gait belt on them? It's kind of defeating the whole purpose of the gait belt. So remember, it has to be applied when the patient is sitting over their clothing. Again, why did they have to make that a checkpoint? That tells you that there's some people out there testing doing some really funky things with gait belts. How do we know that it's tight enough? 4 fingers. When we help our patient stand, we're going to count to 3. And where should their hands be? On your shoulders. Where should your hands be? On the gait belt. Where? On the front? Sides or back, depending on how large your patient is. This is an up close and personal skill, guys. While you're walking the patient, you should be asking them how they feel, right? And when you go to sit them back down, what should they feel behind their knees? The chair. Good. Partial bed bath, face to waist, front and back, 1 arm and hand. That's what we're washing here. It's a washing skill. We want to wash the face first. No soap on the face. Soap stings the eyes and dries the skin. So just water on the face. And then you're going to wash the rest of the body. But when we're washing the face, there's some wet body openings there. So what method do we use? The leaves method. When you're washing the eyes, it's inner to outer corner. To wash, yes, don't go this way. Because your tear duct is here, we want to move away from that tear duct. Okay, good. Remember to control your washcloth. No drippy wet washcloths. Support your arm at the elbow when lifting. Change water if cold or soapy. We're going to turn on their side to wash, rinse, and dry the back. And then what are we going to give them after we wash, rinse, and dry the back? A brief back rub. Yeah, massage. Is this a massage therapy session? No. Yeah, I just want to stick it and make them feel a little better. Yeah, good. All right. And then they should be dressed in a clean, at the end of the skill, clean gown. Good. Wow. 2.5 weeks of learning in 40 minutes. Look how far you guys have come. Now, we've got 3 skills to learn today, but like I said, we're going to rehash what we've learned so far. We're just going to reapply these skills, these principles. So let's go to page 72 in your book. Oh, Anthea says, I want to register to take my state exam. So what is the site I get on for the registration? Good question, Anthea. If you go to my main website, it's the number 4, yourcna.com, foryourcna.com. Up in the top menu, you'll see training, testing, and after certification. Click on testing, and there's test registration instructions on there for you that'll walk you through the whole process. All right, so page 72. Move this over just a little bit. Okay, page 72. Nothing new to learn here. When you're looking at these principles, you look down here, you'll see that skill rules, we follow the care plan. Opening, every skill starts with 1. We always evaluate for gloves because gloves aren't based on the skill, they're based on the patient. shoe rules are going to apply, and the closing. So we already know these. Nothing new to learn there. So what we need to focus on here is just the skill specific. As always, I have a video for you. I've got test specific information down here, and all the principles are detailed here for a review for you. But just as an overview, nothing really new to learn here. If you look at page 73, you'll see the care plan at the top of the page right here. It tells us to transfer the resident from bed to wheelchair. The resident is unable to walk or take steps. I want to stop there, time out. If you have a pen or a highlighter, I want you to underline that. The resident is unable to walk or take steps. This is going to be very, very important to us in just a moment. So the resident is unable to walk or take steps, but can stand with support. So they're not dead weight, but they cannot take steps. A gate belt or transfer belt is required to transfer the resident, and the resident will stay in the room. Let's talk about the room thing for a second. This resident is going to get out of bed and into the wheelchair, and they're going to stay in the room. That's perfectly okay. There's nothing wrong with that. They have a TV in there. They probably have a window, right? So if I were to leave you in a room and you were facing the wall, would that be comfortable for you? No, it would actually probably feel a little bit like a punishment. Okay, especially for older individuals that spent much of their childhood standing in a corner. When you leave somebody in their room, you must turn that wheelchair so that they have something to look at. TV, window, hallway, roommate, something other than the wall. That's actually a very important checkpoint. Okay. Does that make sense? Well, let's talk about the whole can't take steps thing. This skill requires us to do this as a pivot transfer. That means that the person playing the patient for this, and this is a live skill, so you might be a patient for this. The person playing the role of patient for this is going to be told, don't take steps. Okay, don't take steps. So if you have the wheelchair too far away and that person that's playing the patient is forced to take a step because the wheelchair is too far away, because they're not going to fall. Nobody will willingly fall. They will unconsciously take a step to maintain safety. If that happens, it is a huge deficiency because your care plan says they can't. Does that make sense? So that one statement on that care plan, your patient cannot take steps. That one part of that care plan really dictates how close that wheelchair needs to be. And when I say close, I mean close. Like I probably would struggle to get a piece of paper between my patient and my wheelchair. If you can get more than a piece of paper between your patient and your wheelchair, it is too far away. They're going to have to take a step. Good? Make sense? So let's learn a little bit about wheelchairs. This skill is going to revolve around shoe rules. And our shoe rules are if the patient's feet hit the floor, we talk about their shoes. We've heard that before. But your patient is laying in bed. They're not going to have shoes on. So for this skill, we're going to get them sitting on the side of the bed, and then we're physically going to have to put their shoes on them. So physically put shoes on. Now, for the test, if you get this skill, they're going to try to pair you up with somebody your body size or smaller, and they're probably going to pick somebody that has slip-on shoes, just like you. So that's one of the things that they look around. See, you guys didn't even notice that I was looking at your shoes, did you? You had no idea. That's because I'm a nurse and I assess like I breathe. So do those evaluators. Okay. So when you're doing this skill, you're going to be partnered up with somebody your body size or smaller, and they're going to try to find somebody to partner you up with that has slip-on shoes to make this a little easier for you, a little bit quicker. They don't need to see you tying the shoes and struggling to put them on and all of that stuff. Where do they want to be? At home, in their pool, drinking their Mai Tais. They don't want to be watching you tie shoes. Not really high on their priority list. So they're going to try to make this a little bit easier where they can. Does that make sense? But your responsibility here is to make sure that those shoes are all the way on the patient before you transfer. Because with slip-on shoes, although they are a little easier to put on, they're also usually a lot looser fitting. And when we pivot that patient, we can pivot that patient right out of those shoes because there's nothing really holding them onto the foot effectively. Does that make sense? So they're doing you a favor, but you got to make sure those shoes are all the way on those feet. Otherwise, they'll pivot right out of the shoes. Good? Okay. So we're going to put the shoes on the patient before transferring. This kind of cracks me up. So if you go look at my video on YouTube for this, I've got, I don't know, a couple tens of thousands of comments on this video. But it really kind of cracks me up because there is a debate. You have to scroll down a couple years, but there is a debate on this. And lots of people chimed into this debate. A lot of people think that you should put the shoes on before you get the patient sitting on the side of the bed so that their socks don't hit the floor. Well, that kind of makes sense, right? We know the floor isn't all that clean. So that kind of makes sense. But by putting the shoes on in bed, what are you doing to those sheets? Yeah, so there's no real good way to do this without some contamination. Okay, everybody understand that? I'm in the pivot the patient onto the side of the bed first and then get the shoes on camp. And the reason for that is I can change the socks pretty easily.
So on here it says use position wheelchair on the patient's stronger side. Do you have to ask them because it doesn't tell you what their stronger side is?
Okay, so for the test, it's not going to matter because they don't have a weak or strong side. So for the test, that's not going to play into it. I put that in there because we'll get into this next week, but you guys are brand new, right? We've gone over all of this review. You've told me all the principles. You remember all the skills, and that's great. And you're going to test and you're going to pass, and that's great. But when you get out there to work, you're not going to remember all of this. You're just not. I've shoved a ton of information at you in a very short period of time. So you're probably going to be taking this book with you when you go to work, at least for the first couple of days or weeks. It's not unusual. And in fact, it's kind of funny that some of our local employers actually have this book on their policy and procedure shelf for you. Okay. So you will be referring back to this book throughout your career. So there are some things in here that I put not necessarily for the test, but more for what you're going to encounter in a clinical setting. Great question. But for the test, no stronger or weaker side. They don't overcomplicate this. All right. So I'm in the let's put the shoes on when the patient's sitting on the side of the bed camp. Don't put the shoes on in bed. The other problem is when you're trying to turn a patient so they're sitting on the side of the bed, those shoes can get really clunky and unwieldy and kind of get in your way. But for the test, it's important to note that either way is fine. Either way is fine. They don't care. As long as your patient has shoes on before they transfer, that's the checkpoint. So I bring that up because it's important that you understand this test is not trying to fail you. They're not unreasonable. In fact, they're way more lenient than I would be. You don't want me testing you. You don't. I know these skills inside and out, backwards and forwards. You do not want me to test you. You want those evaluators. But they're not unreasonable. They're not trying to fail you. They're not trying to trick you. In fact, here's something you guys don't know. Those evaluators, if their pass rate goes too low, they have to be monitored because that tells Prometric that they're being too difficult in their grading. So they're monitored. They look at their pass rates and fail rates. So if you've got all of the evaluators are hanging right around 75% pass rate, and you've got one that's got a 50% pass rate, they're probably grading a little too harshly. Let's give them a look. Does that make sense? So they're graded as well. A lot of people don't know that. A lot of people, this isn't trying to fail you. They're way more lenient. And this is one of the ways that they're more lenient. Okay. Remember, slipper socks are not enough to keep our patients safe. We already know that. We know that gait belts are applied around the patient's waist, and we use 4 fingers to check it. And we're going to verbally state that their feet are flat on the floor, or ask them, are your feet flat on the floor? And then we're going to count to 3 before we lift them. We stand at that oblique angle that we've talked about. And before we sit them in the wheelchair, we're going to ask, can you feel that chair behind you? I'm going to give you a different way of doing this for the skill, and I'll tell you why in a minute. Now let's look at some skill-specific steps, and this is what I had you underline. They're unable to walk or take steps. So we need to pivot that patient into that wheelchair. Do you see how far away that wheelchair is? If I pick that patient up and turn them around, are they going to be able to just immediately sit in that wheelchair? It's too far. So that means that we've got to make sure we get that wheelchair close enough to the patient that they aren't taking steps. So let's talk about the wheelchair. This is Wheelchair 101. Okay. So this is a wheelchair. They all work pretty much the same. There are a few small differences that you might find, like the way the brakes are engaged, but pretty much they're pretty consistent. To move a wheelchair, if I try to roll this like it is, I'm probably going to run into some problems because those little wheels get all tangled up and they'll actually stop me from moving. So to move a wheelchair that's folded, if you tip it up to get those little wheels off the floor, it makes it way more maneuverable. Okay, otherwise you're fighting the wheelchair. To open the wheelchair, you bring the big wheels off the floor. So this to go somewhere, this to open. Good. Wheelchairs are usually in the folded position, and that just helps with storage, helps take up less space. To open a wheelchair, we lift up on the wheels and open it. To close a wheelchair, we lift up on the center of the seat to close it. Not all wheelchairs open and close this easy. Some of them will only open about that far, and then you have to push down on the seat to finish opening it. Nothing wrong with any of those styles, but if you're going to press down on the bars to open this seat, don't have your hands like this. If I put my hands like this, as that seat opens, it's going to pinch my hands. So if you're going to press down on the seat, keep your fingers out of the way as you press down. Okay, that'll keep you from hopping around, shaking your hand. Hurts. When we're going to put a patient in a wheelchair, it's got to be open. If we're going to take them somewhere, it's got to be open. But when we store it, we're going to close it before we store it. And we're going to talk about those foot pedals and leg rests in just a minute because those have to be adjusted as well. So we'll talk about that in a second. But let's get to brakes. So this is this. I just took a picture of it and highlighted it so that you could see it. So on the wheelchair, right here in front of the big wheel is a lever. If I pull back on the lever, this bar bites into this wheel and the brake is engaged. So over here, there's a lever in front of the wheel. If I press back on the lever, the bar bites into the wheel and the brake is engaged. Now it's not moving anywhere. You can see that here. You can see that there's a gap. The wheel is able to move freely. Once the brake is applied and the bar bites into the wheel, the brake is engaged. Good. Now this particular wheelchair, the brake is engaged by pulling the lever back. You can see the lever here. We pull it back to engage the brake. The other wheelchair that I have in the back closet, that one you push forward to engage the brake. Same mechanism, just a little different action. Wherever you go to work, they'll train you on those wheelchairs. If you get this skill for the test, they will train you on the wheelchair before you do your test. Okay, good. Our cardinal rule here is that if the wheelchair is not actively moving, the brakes should be on. Okay, the wheelchair is not actively moving, those brakes should be on. And that's because of this. Floors are rarely level, especially in Florida. We do not have level floors. We build on sand. Sand shifts, especially under weight. And that means that our floors are going to kind of bow and warp a little bit. Wooden floors up north, they definitely warp. So floors are rarely level. If you have a wheelchair and you have a patient in the wheelchair and those brakes are not engaged and the floor is not level, that wheelchair is going to roll. And the only thing that stops that wheelchair from rolling is whatever it runs into, which is probably going to be another patient or a wall or maybe even down steps. So this was the most expensive lawsuit in the state of Florida. And it happened to be a woman who was strapped into a wheelchair using an illegal restraint. And she had dementia and she was able to get out and fell down concrete steps and ultimately died. This is a multi-6-7-figure settlement with the family. So what we do matters, okay? Certainly mattered to this facility when they had to come up with that kind of money. It certainly mattered to the patient's family. And it certainly mattered to the person that killed this patient. Because they have to live with that on their conscience. And make no mistake, that CNA killed this patient. So when I give you these rules, there's always a reason behind it, a story. We don't want to be part of that story. I've got to update this because now the largest negligence verdict in Florida is actually not this one. Yeah. We now have a new verdict in Florida that is way bigger than this one. So brakes are not a restraint. A lot of people think they are. You put a patient in a wheelchair, you put the brakes on, they're not a restraint. They are there to keep the patient from rolling into or down somewhere they shouldn't be. They're not a restraint. If this patient can go somewhere, they can dislodge the brakes and go wherever they want to go. If they can't propel themselves, they definitely don't need to be in an unlocked wheelchair, because if they can't propel themselves, they can't stop themselves. Does that make sense? Okay. Brakes are not a restraint. Putting a seatbelt on a patient in a wheelchair, that's a restraint. What do we need to be able to use one of those? Doctor's order. That's right. All right. Those that are unable to control a wheelchair need us to keep them safe. And we do that by making sure those brakes are locked every time they're not actively in use. So let's talk about wheelchair height. This is actually a little more important than you think it is. So if you look at this wheelchair, this is what you see here. Let me pull it over a little bit. I know that table's in the way, guys. Those of you at home, you can look at the picture. Those of you here will be able to see it live. Do you see how much higher that chair seat is than this one? Do you guys see that? You can see it on the screen pretty well. Wheelchairs are higher than regular chairs on purpose. Well, it makes sense. The whole purpose of a wheelchair is to make the patient mobile. We don't want their feet flat on the floor if we're trying to push them somewhere. They're going to get in the way. So wheelchairs are always a little bit higher. That makes sense. What you probably don't know or haven't thought of is the effect that has on circulation. And that's because we want the patient's feet off the floor to move them places. And that's going to cause their legs to dangle. Okay, dangle. When you have legs that dangle, this edge of the seat is going to bite up into the backs of the knees. Now, this is the backs of your knees. There are lots of blood vessels back there, and they're all really close to the surface. So when you have a leg that is dangling and that seat is pressing up into it, it's actually pressing these blood vessels closed. And that's what it looks like if you looked at the wheelchair from the back. If we were to look inside the patient's legs, it's going to crimp those blood vessels closed. Well, when you do that, it causes fluid to accumulate in the lower legs because it can't get back to the heart, and that causes swelling. But there's something else that's a problem here. And if you remember talking about shoe rolls last week, I said that anytime blood slows down or stops, it tends to, you guys remember what it does? Anytime blood slows down or stops, it tends to clot. We're slowing down blood. So what is this patient at risk of? Blood clots. Is that serious? So when we have a patient in a wheelchair and their legs are dangling, we have to address that. You cannot just put a patient in a wheelchair and let their legs dangle and be okay with it. That's what the leg rests and foot pedals are for. The problem is that these things come off very easily, and they'll get thrown in the soiled utility room for somebody to clean, or they'll get lost somewhere, and now we got a wheelchair without footrest. So Henry will be fine. Just put him in the wheelchair. He'll be fine. Is Henry going to be fine? No. So if we're going to use wheelchairs, we have to make sure the leg rests and the foot pedals are attached. These literally just set on 2 pins. That's it. That is how they are attached. Come on. Okay. There we go. They just set on those 2 pins. They fold forward and click into place. Listen to the click. That means they're locked forward. Now they're not going anywhere. Foot pedals fold down to support the patient's feet. Now we don't have pressure on the backs of the knees, and our patient is much safer. So when we have a patient in a wheelchair ready to go, the leg rests come forward, the foot pedals fold down. But you can't get a patient into or out of a wheelchair when it's like this, because that's a tripping hazard. So if we want to get a patient into or out of the wheelchair, we're going to fold these up. We're going to release the catch on the back and fold those out of the way. And now I've got an open wheelchair for our patient to get into or out of. Good. If we're going to fold the wheelchair for storage, these leg rests go forward, but the foot pedals stay up. And we collapse our wheelchair. If you bring those leg rests out to the side, if I release this and bring my leg rests out to the side, there's nothing to keep them there. They flap, and the risk of them causing injury is pretty high. So when we're storing the wheelchair, folded with the leg rest locked in position, foot pedals up. Good. Now this is actually pretty easy. I mean, most people can figure out how to use a wheelchair. It's not rocket science. But this, what I'm about to tell you, has everything to do with knowing your role. Because there's always little pieces, even though you can figure out how to use a wheelchair, there's always little bits you don't know. And that's what you should be afraid of. It's not what you know that'll get you in trouble. It's what you don't know that you don't even know you don't know. Good? So let me explain what I mean. Oh, sorry. Let's get into blood clots real quick. So when this vein gets compressed, the valve inside the vein is going to get stuck. That's going to hold blood cells there. Those blood cells will clot, and that will actually form a blood clot in the patient's lungs, in the patient's legs that can travel to their lungs. So foot pedals are important. We're going to swing the leg rests out to the side when we are getting somebody into the wheelchair, and we'll lock them forward for transport or during storage. So this is what it should look like. While in use, your wheelchair should be open, foot pedals and leg rests in the forward position. When stored, leg rests in the forward position, foot pedals up. Hold on 1 second. Give me 1 second, guys. Oops. Okay. Quick break. Quick break. Sorry, guys. Those of you live, quick break. Take a break. We're here.
Yeah, I work at a pharmacy, so we have to have like the biggest background that you could possibly have.
Can I start out with people? You know how you said that one paper comes with you to the class? That whole pamphlet thing, she said that when they send, when you do it online, or even if you send that in, you're gonna get an email for your date, so then you have to print that out. They're gonna send
So
you
you
a
have
follow.
that paper,
Yeah,
just not the paper that has the application on it, right?
yeah, just the stuff that you filled out. But if you do it online, or if you don't do it online, they're still gonna send you that, and then you, open up all the attachments, and then you, print it out. If you don't have a printer and you go to the class or something, they'll get them look it up for you, but you kinda wanna bring it,
Yeah, just saves some time.
yeah. I asked her that this morning. Oops. They just kind of, yeah. Let's get on this one. I'm staying up. You're staying up.
And we'll do that background check. I don't really have some time again in class.
Yeah, Monday, see if you're so from two you have that break, but then
So then
that's
I'm
like,
able to practice.
yeah. Only during class.
Does she do hands-on in class? Like, do you guys get to do hands-on stuff?
Yeah, we started it yes,
Yes. Okay.
Monday,
I haven't been here at all. Work is not giving me. I put my little headphone in while I'm counting. I'm like listening to what she's saying, and I'm like, yeah, I understand some of this.
Yeah, me too. What helps though is the videos.
Yeah, it's nice to go back and be able to watch them. Which, I mean, if I had known that the videos were free, I would have taken this because I can learn everything from them. You know, but they don't tell you that. So, kind of just sitting here. And she's like, oh yeah, we have free videos. I'm like, I was broke when I did this. Okay.
Yeah, I know. And you haven't done one for 12 months, right? She gave, you can look at them for 12 months.
Oh, it is humid out there. Oh,
I have a couple questions for you.
okay.
So, because I haven't been here, so the test we have to pay for separately, correct?
Right.
If I've had background checks, like, I had worked in a pharmacy, so we have to have a background check, like, constantly.
Right.
Do I have to get another one separately?
I don't know. And there's no way for you to find out.
Okay, so that means just do it anyway.
It's a horrible answer, I know. No, so you have two choices, okay? It's a level 2 photo-enabled background screening with medical.
So pharmacy probably qualifies, but I don't know for sure.
Okay.
So I can't give you a definitive. Now, like if you worked for the hospital, that would definitely work,
Yes.
but pharmacy is one of
Okay. So Anthea asks, I have a background check because I work for a facility. So do I just need to give them the name of the facility? And the answer to that is no. You're not going to give anybody information on where your background check is because it goes into something called the clearinghouse. So, Caitlin, you can take that off now if you'd like. It goes into something called the clearinghouse. So let me explain how this works. About, I don't know, 10 years ago or something, Florida voters had the option, not just medical, but all Florida voters. They said, okay, a lot of you guys need background checks for your, work or whatever is going on. You need background checks for lots of things. So we can just put it all into one big bucket. And that way, when you get a background check, everybody can check it. You don't have to keep going for background check after background check after background check after. And Florida voters said no. They said, we don't want our information shared with anybody. We'll just keep doing things the way that they are. Well, out of that came the clearinghouse. So even though Florida voters didn't want that for everything, we did enact it for medical. And what that means, because it used to be, before this happened, it used to be you had to get a background check for the test, and then you had to get one for work. And if you changed employers, you had to go get a different one for your new work. So it was all based on the employers. So imagine, these background check companies are running the same background on the same people all the time. So they created the clearinghouse. So when you get a background check done for medical, it goes into the clearinghouse, and then anybody in medical can access that background check. So it's not based on your employer. So Anthea, you're not going to tell them who your employer is to go find the back. That's not how that works. You're simply going to register for the test. They will look in the clearinghouse. If they find you in the clearinghouse, then they're going to use that background. If they don't find you in the clearinghouse, they're going to send you an email that says record not found. We need to get you into the clearinghouse. And you'll need to renew that every 5 years. So every 5 years, you have to go get a photo-enabled background check. Your employer will remind you because they can't let you work without one. Okay, so good? Questions on that? Oh, thank you. Awesome. Okay, so let's figure out where we were because I didn't write it down. Pretty close. Okay. Let's go back here. Sorry. Recap real quick. All right. When in use, leg rest forward, foot pedals folded out to support the feet. In transit or storage, leg rests out so they don't flap and hit somebody, but foot pedals up. When we're transferring somebody into or out of, everything out of the way. Good. Now, you might possibly have a written test question that gives you graphics and asks you which is the proper preparation for a wheelchair when you're getting ready to transfer somebody in. And you would have to choose. Okay. You don't want anything in your way when you're trying to transfer. Keep that in mind. Because that's what happened here. A lawsuit in Georgia. This was a really sad situation. And I really feel bad for this lady. I really do. So in Georgia, there was a woman who went for like an x-ray. Okay. And she was an older woman, had trouble walking. Her daughter goes, they're done with their appointment. She's in a wheelchair. The daughter goes and gets the car to bring it up front so mom doesn't have to walk so far. Daughter brings up the car, and a transporter was not there to help her transfer, right? So there's a registration clerk or a secretary or a non-clinical person. And she's like, it's all right. I can help you because they're sitting there waiting. The car's taking up space. We got to move this along. So she says, no problem. I'll help you. She takes the patient outside in the wheelchair and tries to transfer her from the wheelchair into the car. but did not move the footrests. Didn't think about it. She hadn't been trained on it. So the patient got tangled up in the footrests, fell, and broke her leg. Now, here's a registration clerk that was just trying to be nice. She was just trying to help. This wasn't a situation where she was trying to cause injury or being neglectful in any way. But at the end of the day, our patient still got a broken leg. And that doesn't help them. So the facility was sued. And the facility was sued because this person acted outside of their scope of practice. They were not trained on using a wheelchair. Now, do you think that, now I feel really bad for the registration clerk because like I said, she was just trying to do a good deed, right? No good deed goes unpunished. But do you think that lawyer felt bad for her? Man, that lawyer grilled her, drug her through you know what and back. Was this in your scope of practice? Here's the policy procedure. Show me in your job description where it says you're supposed to do this. Were you trained on this? I mean, just, it was brutal. And all this woman was trying to do was a good deed. So be careful here, okay? Lawyers don't make their money off of being nice. They make their money off of proving that you did something that hurt someone else. Accidentally or not, doesn't matter. So be careful. Do not do things that you have not been trained to do, no matter how minor you think it is, because accidents do happen. There's always something you don't know. Does that make sense? Always something you don't know. So before we transfer our patient, we're going to prepare the wheelchair by folding the foot pedals up and moving the leg rests out of the way. And then once the wheelchair is prepared, we'll pivot that patient to sit on the side of the bed. Now, I'm going to show you how to do this. Not nearly as hard as people think it is, but you can easily pivot somebody to sit on the side of the bed, and then we'll put some shoes on them. Once they have their shoes on, we'll put the wheelchair super close. You can put the gait belt on anytime you get them sitting up. So you want to put the gait belt on before you bring the wheelchair over, that's fine. You want to do the gait belt before you put the shoes on, that's fine. Nobody cares when the gait belt goes on, as long as it's when they're sitting and over their clothing, okay? So don't get caught up in the order here. But gait belt on, shoes on, wheelchair close, and locked. If we don't lock that wheelchair, we try to put somebody in it, what's going to happen to the wheelchair? Yeah, it rolls away. Absolutely. So we want to make sure when we put that gait belt on that we check it with 4 fingers. We're going to use that same oblique angle, and we're going to lift our patient using body mechanics, swing them around. Should they take steps? Nope. And we're going to make sure they can feel that chair and sit them down. Then we want to make sure that they're sitting properly in the chair. The hips are back against the back. We take the gait belt off, you know, that they're comfortable because they're going to be there a little bit. And then once we do that, we'll swing them around. Remember, they should not face the wall, and lock that wheelchair. Remove the gait belt. And then give them their call light and do your closing. So this isn't a hard skill. It really isn't. It takes me way longer to explain it than it does to do it. It's not a hard skill. But this one is 100% safety. So if you make a mistake on this, it's going to count big. One mistake can potentially ruin this skill for you because everything is safety. Okay. So I'm going to ask you to come over. And I want you to lay down in the bed for me. Take your shoes off and just leave them on the side of the bed and lay down in bed for me, if you would. All right, so I'm going to simulate hand washing just for the sake of time here, but I'm going to do this entire skill from beginning to end to show you how to transfer a patient from bed to wheelchair. Now, the one thing that I want you to remember when you're doing this is when you stand the patient up and you pivot them, You don't want to be holding their body weight for a long period of time. If I stand the patient up and pivot them and then ask them, can you feel the chair behind your knees? And they have to think about it and then say, yes, that's a long time for me to hold the patient. So listen to what I do instead. Okay, because I don't want to hold this patient's weight. Turn this. Oops. Yeah, over here is fine, wherever. Thank you. I know I really need to put the camera here, but I'm afraid people will trip over it. I gotta figure this out. All right, here we go. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Fantastic. Do you feel like getting out of bed and into the wheelchair? Okay, I'm going to close your curtain. Let me go wash my hands, get my supplies. I'll be right back. I've washed my hands. I'm going to get the gait belt. I'm going to open the wheelchair and just get it prepped. We're not going to get it close yet, just prepped. Within reach. And we're going to leave it right there for a minute. All right, Miss Jones, can you scoot your whole body toward me? Okay. I'm going to pivot you around so you're sitting on the side of the bed. I'll do all the work. All you have to do is relax, okay? I will want you to cross your arms over your chest for me. Now, when I do this, I'm going to get her sitting on the side of the bed. This arm is going to go underneath her shoulders all the way across. Her furthest shoulder should be in my palm. Not a little bit, all the way. This arm is the one everybody messes up. It doesn't go under. It's not a honeymoon carry. This arm goes under, this one goes over. And when I do that, we just pivot. Now, I'm going to use some leverage to my advantage. So the bed is locked. I know it's locked. I can feel it locked. I'm going to lean my legs against the bed to use it as leverage as I pivot. Okay, so let me just get my hand underneath your shoulders here. Okay, and on the count of 3, we're going to pivot. 1, 2, 3. Feel okay? It's a pretty quick turn. Okay, you good? Dizzy?
No.
All right. Let me go ahead and put your shoes here. Slide your foot in. And slide that foot in. Okay. Are your feet flat on the floor?
Yes.
I'm going to put this gait belt around you. This is going to help me get you into the wheelchair. Remember, we want to make sure it's not twisted. Put it through the first guard by the alligator teeth. And we're going to snug it up. How do I know it's snug enough? 4 fingers. I can fit 4 fingers there. Put it through the second guard. And then we'll just tuck that tail out of the way. Now I'm ready to transfer. So I'm going to bring the wheelchair close. 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 Do you guys see how close that is? I don't know why, but students do that. The floor is not level. Okay, it's got to be way closer than this. If I pick her up, she will have to take a step. So, close. Once we get it close, we're going to lock that wheelchair. Okay. And I'm going to put my foot in front so her feet don't slide out. Okay, in just a moment, you're going to place your hands on my shoulders. I'm going to pick you up on the count of 3 and swing you around. When you feel this seat behind your legs, I want you to say, sit. And I'll help lower you into the chair, okay? So you're going to put your hands up here. When you feel the chair, you're going to say, sit, and I'll help you sit. Ready? 1, 2, 3.
Sit.
Notice I'm not holding her weight. I prepared her before the turn, so it made it a little easier. Now we'll remove the gait belt. Can you lift your arm up for me? Thank you. Very good. Okay, I'm going to unlock the wheelchair and spin you around. Ready? Lift your feet. Very good. And remember, we do not want her facing a blank wall. So I'll get it in position, lock the wheelchair, and I'm going to place her foot on the foot pedal. Come over here and do the same. Bring the leg rest forward, lock the wheelchair, lift her leg, and place her foot on the pedal. Good? Are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I leave? Here's your call light. If you need anything at all, please let us know. And somebody will be down later to take you to breakfast. Environment is clean. I'm going to open the curtain. Put my gate belt back. Wash my hands. Think about the steps of my skill. Make any corrections. My skill is done. Okay, don't get up. I got to get that footrest out of the way. Okay, go ahead and lift your foot up for me. Okay, lift this foot. Oh, okay, now you're free to roam the building. All right. Any questions on that? Any questions? No? Okay. So wheelchair safety takes us way longer to learn than do. All right. So now we're going to go into feeding. This is on page 108. Feeding does not follow our normal rules. It is a rule breaker in a lot of different ways. And we're going to talk about how feeding is different from what we've learned so far. But if you look at this page, you can see there's nothing new to learn here. You know all of the principles involved. No new principle to learn. But we do need to learn skill-specific steps. So if you look at the top page 109, you'll see the care plan for this skill that tells us to feed the resident a snack who is unable to feed him or herself. Patient is sitting in a chair at the side of the bed. And an inappropriate position for eating. I'd like you to underline that. If the care plan is telling us that the patient is in an inappropriate position for eating, it doesn't matter what your eyes say. Okay. This is a live patient skill. One of you guys might be a patient. Means you might be getting fed during the exam. And it's going to be a single serve pudding or applesauce cup. Now, when you're the patient for this, so I want to talk to you not as the CNA doing the skill. I want to talk to you as the potential patient for this skill. When you're the patient, you're going to get very specific instructions. The first thing they're going to do is tell you to sit down in that chair and slump or slouch. Your idea of slumping or slouching might be different from mine. But they're going to tell you to slump or slouch. They're also going to tell you to only take 4 bites and then refuse. 4 bites. That's all you're taking. If you don't happen to like applesauce, can you choke down 4 bites? Please. Okay. So remember, pudding or applesauce is what they're going to give us. Now, the reason I talk about this whole inappropriate thing is because for some people, slouching is this. Now, your eyes might tell you that this is not a bad position for eating. I mean, 12-year-olds the world over eat like this all the time. So in your mind, this might not be an inappropriate position for eating, but what does our care plan say? It is inappropriate. So we must address this. And we simply address it by asking them, can you sit up, please? That's it. Now, for some of you, my theatrical people, when you're told to slump or slouch, you're going to do something like this. Okay. Now, that is clearly an inappropriate position. Your eyes will agree with that. But it's important that you know that it doesn't matter what your eyes are telling you. The care plan tells us it's inappropriate. Then it tells us to document their intake on a food and fluid intake form, which we're going to get into in just a few minutes. But let's learn a little bit about what makes this different. So feeding is a skill that doesn't follow a lot of our normal rules. Number one, we don't close the privacy curtain when we feed a patient. And that's because eating is a social event. Think about all the things you do in life that revolve around food. Think about it, right? Baby showers, weddings, funerals, graduations, birthday parties, celebrations. All of those things are always revolving around food. Even normal backyard barbecues revolve around food. Food is an integral part of our social experience, but it goes beyond that. You've been trained from the time you were about this big, don't talk with your mouth full. You know not to do that. But that doesn't mean you're not socializing and talking while you're eating. If you go over to Cody's, by the way, that's buy one, get one fajita day. Yum, right? So take a friend. You go over to Cody's today after class, it'll be packed. So when you walk in, there's 60 other people in there. Is that place silent? No, what do you hear? Conversations. Well, hold on. You were told not to talk with your mouth full. So how are there conversations going on? Between bites. That is exactly it. Between bites. So when you are feeding somebody, understand that conversation is a normal part of the eating experience. So what do you think you need to do when you're feeding a patient? Have a conversation. And for the test, it is graded. What you say isn't graded, but the fact that you're having a conversation is. Does that make sense? Super important. If you feed somebody in total silence, it is awkward. And your patient won't eat. So this skill requires that we don't close the privacy curtain because we need that social interaction. But it also requires that we have a conversation. The TV is not there to socialize your patient. You are. You're being paid to do that. So when you're socializing your patient, a lot of people get stuck on this. What does that mean? What kind of a conversation do I have to have? Well, for the test, it doesn't have to be real. You can make something up. I see they're playing a movie on the big screen today. Do you want to watch it? Or they're playing bingo. Or did you see those little kids in their Easter costumes? Weren't they adorable last week? They were just amazing. I don't care what you say. For the test, what you say isn't graded. The fact that you're having a conversation is. But I want to give you a couple of tips for real life, because this is way more important in real life than it is in the test. So what do you talk about in real life? Well, the first thing you should do is look around the patient environment. Patients will put up pictures of things that they are okay talking about. Right? We don't put our deepest, darkest secrets on our wall. Those go in the closet. Okay. So if I've got a picture up there of me and a cruise ship, that means that I am more than happy to talk about cruise ships, my husband, the fun that we have. I'll talk to you all day about cruising. Give me an opening. Okay. Because it's out there and it's visible. So if your patient has pictures on the wall, ask about the pictures. Again, they'll talk all day. All you got to do is give them an opening. That's it. That's all you got to do is ask the question and they'll start talking. What I like to do, especially with older individuals, is there's always a black and white photo of a woman that's dressed. These women put us to shame, ladies. Man, they knew how to put themselves together. They all looked like they came out of a magazine, every one of them. So Isla, if there's a picture, a black and white photo of a woman dressed to the nines with a man in a military outfit, they're universal. I will say something like, oh, what a beautiful couple. Did you know them? Are they movie stars or something? Did you know them? And watch her sit up a little straighter and go, oh no, honey, that's me. Yep. Oh, I see it. Look at your eyes. Now, what I've done, I may not mean it. I probably do because that's who I am, but I may not mean it. But that means absolutely nothing because you know what I did? I made her feel good. And do you know what that's going to do for her appetite? It's going to improve it. That's right. Did it cost me anything? No. So I always try to find a way of making my patient feel good before I feed them. Always. Because it improves the appetite. It gives us something to talk about. Oh, where were you? Was he the one that got away? You know, I'll ask questions like that. And I know they're leading questions because he clearly didn't get away, right? So now I can talk about their life together, where they were, their family. Gives me a whole bunch of stuff that I can have a conversation about. But sometimes your patients don't have visual cues. They don't have anything that you can ask about, especially if you're in a dining room. So there's always a few questions that I have in my back pocket that I pull out for conversation starters. People will talk about themselves. All they need is an opening. You want to be known as a great conversationalist? Learn to ask good questions. Okay. So one of my favorite questions that I ask is, what's the most exciting place you've ever been? I'm thinking about going on vacation and I'm not real sure where I want to go. So what's the most exciting place you've ever been? I'm looking for ideas. Now they think they're helping me. So what are they going to give me? Yeah, a list. Experiences. They're going to reminisce. And when you reminisce, you generally feel better. Okay. Again, I'm stimulating that appetite. But sometimes your patients will surprise you. Let me tell you about the most interesting conversation I ever had with a patient. And it started out like this. Now, she was in an assisted living facility. She was in her mid-90s, still very much mentally intact, but had some mobility issues. And she had a lot of wounds on her legs that needed to be dressed. Now, this was a very extensive dressing process. I had to take the whole old dressing off, clean the wounds, put a new one on. And it was probably about 45 minutes it was going to take me. So I'm pulling out my questions. So what's the most exciting place you've ever been? And she says, oh, honey, I've never been anywhere. Now, this is in Citrus County, just so that you can set the stage. Little old sleepy Citrus County. And I said, oh, you had to have gone somewhere. I mean, it's Citrus County after all. And she says, no, I've never been out of the county. What? You never went to Ocala? You never left Citrus County? And she says, well, that's not entirely true. I was born in Brooksville, but I don't remember that. Oh my gosh. Now I'm pulling up a stool. We're going to be here a while because this is living history. This is someone who thinks she has nothing to offer, but she has been in the same place for 90-something years. I can get more out of her than I can out of a dusty textbook to tell me about the growth of this county. What changes have you seen in your lifetime? So things like paved roads. Those are things we take for granted. Paved roads. Oh my gosh, this is somebody that was around before paved roads. She remembers when the courthouse was moved, when the new courthouse was built, and what a huge controversy that was when they moved the courthouse. There were two families in Inverness that didn't really get along, and the son from one family was supposed to marry the daughter from another family, and she ran off with another boy, and that was a huge scandal. And she talked about that scandal for like 30 minutes. a huge scandal. She remembers when the first McDonald's came in and there was a parade. So interesting, but she didn't think she had anything to offer. So all you have to do is know what questions to ask. I ended up staying there well after the dressing was done, just because of the information that she was giving. It was fascinating. Fascinating. I've met somebody that was knighted by the Queen of England. Wow. What a story. I met a man who was an engineer for the Apollo missions when we sent men to the moon. I met a Major League Baseball player. All you have to do is ask the right questions. You don't have to talk. A lot of people get all tied up in this. I don't know what to say to the patients. I don't know how to talk to strangers. You don't have to talk to strangers, because after a few minutes, they're going to be your friend. All you have to do is give them an opportunity. Make sense? But for the test, you have to do something along conversation lines. Okay? Good? It's the only skill that we are required to sit. Bless you. Now, the reason that we're sitting is because if you stand over somebody, this is a power dynamic. Okay? If you're standing over somebody and they're seated, there is an inequality of power. They will feel rushed and they will not eat well. So you are required to sit eye to eye with your patient to feed them. Do not ever feed a patient standing up. That's a big no-no. So there was a patient that we were caring for in a nursing home a long, long time ago, but she was dropping weight. I mean, she was dropping weight significantly. And, I'm talking to the doctor, we're ordering tests, something's got to be wrong with her. And, as we're trying to figure out what's going on with her, I was walking down the hallway one day and I saw the CNA that was feeding her in her room. And the CNA is standing over the patient facing the TV. The patient is here. How do you think that patient felt? A burden. So when you feel like a burden, what are you going to do? You're not going to eat. Yeah, the patient was losing weight, not because she had something wrong with her. It was because we had incompetent staff members that were treating these people like cattle, not people. We can do better than that. So we are definitely not going to stand over a patient. We're going to give them our full attention and we're going to make them feel good about themselves. I don't care how you do that, but do it. And that gets your patient to eat. Because what happens to tomorrow's energy levels if they're not eating today? Yeah, you are literally 3 weeks away from killing somebody. You treat them like that and they stop eating, it is a downward spiral and it will kill them in about 3 weeks. It's called failure to thrive, and it happens all the time. I'm going to show you Peri-Care in a little bit, which is a below the belt cleaning situation. You're not going to be comfortable with it. Your patient's not going to be comfortable with it. And you would think that that is the hardest skill to be a patient for, but it actually isn't. This is. Being fed is the hardest skill to be a patient for in real life. I'm not talking about what you guys do. I'm not talking about playing around, feeding somebody, practicing for the test or testing. I'm talking about real life. I can't feed myself anymore. That is the hardest skill to be a patient for, because it's the very first skill you master in life. This hits you psychologically in a way that no other skill will. You learn how to hold a bottle long before you sit, stand, crawl, or walk. You learn how to pick up things off a high chair tray and get them into your mouth long before you know what hunger is. You learn to eat. You become independent at eating before you master any other skill in life. So when you lose the ability to feed yourself and you have to rely on another human being to feed you, it affects you psychologically in a way that no other skill will. And because of that, a lot of people are reluctant to be fed. And if you do this with even a trace of irritation or rushing or make the patient feel at all like they're an imposition, they will stop eating. And what happens when we don't eat? We die. You are holding their life in your hand. And they know it. The worst case of negligence here in Florida, thank God I did not have, put me in a room with this person. 15 minutes is all I need. There was a CNA who had a patient that had to be fed and would put the tray in front of them and they could see it and they could smell it. And then the CNA would chart refused, wouldn't feed them. All I need is 15 minutes in a room with them. That is torture. That is horrid. I don't care how busy your life is. Don't ever do that to another human. Can you imagine being starving, seeing and smelling the food? It's right there. And then they don't feed you. That's not just physical torture. That's psychological torture. It's horrible. And yet that happened right here in Florida. Not just to one patient, but to several. Yeah. And she got caught because she was in a room eating the patient's food. Yep. So this is a skill that they're going to be watching all of these little details. Do you guys understand why I'm telling you all this? They're watching all of these little details. And they're going to grade you on it. So we've got to make sure that we get our minds straight when it comes to feeding a patient. It's not just about putting food on a spoon. It's about how we make them feel while we're feeding them. So a lot of this has to do with that. We're not going to close the curtain. We're going to have a seat. We're going to talk to the patient and have a conversation. We're going to make them feel like we want to be there, that this is important to us, okay? We don't use a barrier for this because our food tray is our barrier. You don't need a barrier on the table. You can use one if you want, but it's not necessary. So for this skill, severe thunderstorm watch, guys. Make sure your windows are up. We want to make sure the patient is sitting fully upright. Remember our care plan said they're in an inappropriate position for eating. Doesn't matter what your eyes say. You're going to ask them, can you please sit up straight for me? Okay. We want to offer a hand wipe before we feed them. Now, I know I'm feeding the patient, but even though the patient can't feed themselves, it doesn't mean that they're paralyzed. Remember, don't add to the care plan, right? So what if something's sliding out of their mouth and they bring their hand up to get it back into their mouth? We don't want dirty hands up near our portals of entry, so give them a hand wipe. But it also goes to ritual. Most people wash their hands before they eat. It's part of the eating ritual. So by giving them a hand wipe, it can help stimulate appetite if that's part of their eating ritual. We're also going to offer a clothing protector. We do not call it a bib. We do not call it a bib. But you do want to offer a clothing protector. Me, I need one. If I go over to Cody's today and get those buy one, get one fajitas, I'm going to make a huge mess of myself because I wear everything. So you offer me a clothing protector, I'll take you up on it. Offer my grandmother a clothing protector, and she will absolutely inform you that she is not a child. So remember that everybody's an individual and they have their own preferences. So we can offer, but we're going to listen to them. Okay. We're going to sit while we feed them, and we're going to offer a drink every 2 to 3 bites. Now, let me tell you about this real quick, because this is something you probably didn't think about. Everybody has different eating preferences. How many of you guys don't like your foods to touch on a plate? Anybody? Do I have this? Yeah. Okay. How many of you eat all of one thing on your plate before moving to the next thing? Yep. Okay. How many of you like your corn and mashed potatoes mixed? How many of you don't? Okay. So understand that not everybody has the same eating preferences. Don't think that the way that you eat is the way the patient eats. This also goes for liquids. Now, me, I drink with a meal because I always have a dry mouth, right? So when I'm eating, every couple of bites, I'll take a drink to help with things, going down. Some people don't drink with a meal. They drink before a meal. My aunt was like this. She would drink an entire glass of water like this before she ever ate anything. And she literally used the water to fill up her stomach so she ate less. And she had been a model when she was younger. And that's how she kind of kept her, physique. So she would always drink a large glass of water before she ate. I tried it, doesn't work for me. And then some people drink after a meal, right? Everybody has different preferences. So we're going to offer a drink before and every 2 to 3 bites. Now, if you remember about a half hour ago, I told you when you're the patient, the evaluator is going to give you specific information. How many bites did I tell you you'll be taking? 4. So if we're going to offer a drink before and every 2 to 3 bites, by the time the patient hits 4, you should have offered a drink. And that's why the test cuts off there. So make sure you're offering a drink as they're eating. They may not take it, and that's okay. They may not want it, but we're still going to offer it. No childlike feeding techniques here, guys. No planes, trains, or automobiles. We're simply going to feed. We only want to fill the spoon about half full and give them time to chew and swallow. So one of the evaluators when we were at testing center comes out, and she was just like livid. She was so angry when she came out of the testing room. And I'm like, what happened? She said that one of the students that was testing, they call them candidates. One of the candidates was feeding the other one pudding and was so nervous. She overfilled the spoon. I mean, the spoon was like heaping full, shoved it in the patient's mouth, and then just kept going. And like the person had no time to chew and swallow, and pudding is just falling down her face, and she's trying to pull away, and the candidate is just shoving the food in, and the evaluators aren't allowed to correct you. So this evaluator was livid, because she couldn't correct the action. She just had to fail the candidate. So we're going to feed slowly. Give them time to chew and swallow. Spoon should only be half full. So in that situation, who was the candidate focusing on? Her or the patient? Herself. She was trying to get through the skill. Okay. Don't do that. Think about the patient. So you're starting to see some ways that you could fail? Are you starting to see that you will never do the things you could do to fail? Because to you, that's just like madness. Why would you do that? That's so stupid. Why would you do that? And yet, that's what they're trying to weed out. So you guys are well prepared. Okay. Good. All right. So at the end of the test, when your patient says, I'm done, I'm finished, no thank you, I'm full, whatever they're going to say after bite 4, you have to provide at least 2 forms of encouragement. Now, that could be something like, are you sure you don't want just one more bite? I turn up the charm. Come on, one more for me. Just a little one. And usually I can get somebody to take another bite. You also can offer something different. Now, we all do this, but we don't think our patients do it. And I don't know why, because patients are human too. Have you ever made something? Took a bite? Nope, not it. Not what I was looking for. So if we know that we do that, why do we think our patients don't? Right? If your patient's only taking a couple of bites, maybe this isn't it, whatever they're looking for. So I always offer, if they're only taking a few bites, I offer, can I get you something else from the kitchen? Maybe this just isn't it. If all else fails, I let them know, if you get hungry later, let me know. We've got some snacks on the unit we can give you. For the test, you need to use at least 2. Are you sure you don't want just one more bite? Can I get you something else? And we have food here if you want it later. You need to use at least 2. You don't have to use all 3. Pick whichever ones you want. But you really should be using that in a clinical setting. Again, it helps remove that rushing aspect of feeding. And then, of course, we're going to document this skill. Okay. We're going to go through this quickly. Quick review. So we're going to offer a clothing protector and a hand wipe. We'll sit while we feed. I've got a slide for each one of these. We'll sit while we feed them. We're going to offer a drink before and every 2 to 3 bites. We're going to feed slowly, giving small bites with a spoon only, half full. We're going to have a conversation. We're going to encourage intake, and we're going to leave the area around the mouth clean. And then we'll do our closing. Now, this is a documentation skill, so this is your documentation form. It actually has a spot on here that asks, is this a meal or a snack? What does our care plan say? Snack. So we're going to check off the snack box. We're only giving 4 half full spoons. So if we're looking at this quarter scale, right? 4 half full spoons of pudding or applesauce is only about a quarter of the container. If you've given that patient more than a quarter of the container, you overfilled your spoons. All right. So details matter. Details. We're going to offer a hand wipe, clothing protector, drink before feeding, and every 2 to 3 bites. We're going to let them lead. We're going to feed slow, spoon only half full, and no childlike feeding techniques. So let's talk about this quarter scale thing. Get really familiar with this. You're going to be using it a lot because a big part of what CNAs do is document intake. Big part of what we do is document intake. So for food, we use a quarter scale. 100%, that's Clean Plate Club. They finished their meal. Good job. 0%, they didn't eat any of it. They refused it. Anything in between, we're going to estimate whatever it's closest to. So if they ate about a quarter of it, 25%. If they took 1 bite, well, we got to choose 0 or 25%. We have to choose one. Okay. So whatever it's closest to. Well, 1 bite is definitely closer to 0 than a quarter. Does that make sense? Okay. So this isn't an exact science. This is an estimation. Good. So 75 is 8 most. 50% is 8 about half. 25% is kind of picked at it a little. 0 is refused. So if you look at this, you always have to know what you start with to know how much they ate. And this is the example I give for this. Let's say we have a pudding cup and they eat the entire pudding cup. It sounds like 100%, doesn't it? If we have a pudding cup and they ate the entire pudding cup, that's 100%. But what if that pudding cup was on a tray with a sandwich, chips, and fruit and a pudding cup, and they ate the whole pudding cup? Did they still eat 100%? No. Now it's more like 25. Does that make sense? So you have to know what you're starting with to be able to estimate how much they ate. So here we're starting with a sandwich, broccoli, and Jell-O. That does not sound like a good combination, but that's what we're starting with, a sandwich, broccoli, and Jell-O. If you look at the first picture there, can you estimate about how much they ate? How much? What do you guys think? Oh, yep, the one at the top. Sorry, the one top left. Somewhere between 0 and 25. Either one would be fine. They had a couple of bites. Could be a quarter. I mean, it's probably closer to a quarter, but not really enough to write home about, right? What about the second picture there on the top? About a half. Yeah. Remember, it's not an exact science. It's whatever it's closest to. What about the one on the bottom there, on the bottom left? Yeah, they left their broccoli. And what about the last picture there? At 100, yeah. Broccoli stalks, yeah, they didn't like finish. It's not clean plate club, but it's close. And for me, broccoli stalks, yeah, that can be thrown away. That's okay. Some people eat them, some people don't. But they ate the leafy part of the broccoli. Good job. I'm going to give them credit for 100. Good? All right. In your book, go to page 106. Now, on page 106, there is a feeding activity. I want you to take a minute to do the one in the first column, the one at the bottom of the first column. Do that feeding activity for me. Remember, it's an estimation. This part isn't overly scientific. We're about to get to something that is. Okay, so for those of you who are playing along at home, this is on page 106 of your skills book. Okay, so the starting plate was 2 eggs, couple slices of bacon, 2 halves of toast, and some cantaloupe. Number 1, if you went and picked up plate number 1 after the patient ate, how much would you give them credit for eating? 100%. That is an empty plate. I have hiccups. I'm sorry, guys. That is an empty plate. Number 2, we started out with 2 eggs. We have 1 left. We started out with 2 halves of toast. We have 1 left. We started out with 3 strips of bacon. We have 1.5 left. This is a true 50%. Half of everything is gone. Number 3, we got a little bit of egg left, a toast piece left, a small bite of bacon left, and a little little cantaloupe. How much would you give him credit for number 3? 75. And number 4, he took 1 bite of toast and ate 2 pieces of bacon, didn't touch the egg or the cantaloupe. 25. It's not how much is left, it's how much they ate. Good? You guys understand that? All right, so now let's get into something a little more scientific. This, what I've showed you so far, is an estimate, right? And that's how we estimate food. But if your patient is on intake and output, I know these hiccups are going to kill me here. If your patient is on intake and output, we're not just going to estimate the amount of food that they ate. We're going to measure the amount of liquid they consumed. So this is a little bit different. So food estimations are just that. They're estimations of food. Intake and output, which is what you see on page 107, is a measurement of fluids. Now, in most people, in a perfect world, this should be roughly equal. The amount you take in should roughly equal the amount that comes out, with a little gap there, but roughly equal. If you're taking in 2,000 cc's of fluid, but you're only peeing out 600, what happened to the other 1,400? It went somewhere. Where did it go? We got to figure it out. So intake and output is just measuring. So this is scientific, measuring the amount of fluid that goes into and comes out of a patient. Now, it's important to understand that not all fluid is going to go in or come out in the ways that you think it will. So yes, we do take fluid in by mouth. I'm drinking. But fluid can also go in through IVs, through injections, through irrigations. We have lots of different ways of introducing fluid into the body in a healthcare setting. Fluid can come out through urine. That's the one we're most familiar with. But again, fluids can come out other ways, through vomit, through wound drainage, through urine and feces, through sweating. So fluid can come out through other methods as well. When your patient is on intake and output measurements, that means we're physically going to measure how much fluid goes into the body and how much fluid comes out of the body every shift. As CNAs, you are going to be responsible for the fluids by mouth and the urine and feces, if it's liquid, that comes out. All the other things that I talked about would be measured by the nurse. Good? Questions? All right. So in healthcare, all fluid is measured in cc's, also known as ml. cc's and ml's, different names, same measurement. Same measurement. But in America, we tend to measure things by ounces, not mLs. So that becomes a problem. We now have to convert. So prepackaged things will have the mLs right on them. So if you look at that water bottle that you have in front of you, Lucy, can you tell me how many ounces? Excuse me, should be 15.9.
16.9.
16.9. How, right next to it, in parentheses, it should have mLs. Well, 16.9 ounces, but it should tell you how many mLs.
Oh, yeah.
500 mLs. Okay. So the label actually gives you the conversion. So if you look at yours, you've got one too. How many ounces is yours?
It says 16.9.
Okay. And how many mLs? Okay. Your can.
16 ounces, 473 mLs.
Okay. So your Gatorade bottle.
12 ounces, 355.
Okay. So prepackaged items will have ounces and mLs. They do the conversion for you. Super easy. So all you're going to do is write down what the bottle says, right? But sometimes we have things that don't come with mLs. So if I have this cup and I fill it up with water and my patient drinks the whole thing, I've got to know how much the patient took in. So when you go to work somewhere and you go through orientation, they're actually going to tell you the ounces for the cups that they use. So our water cups are 10 ounces. Our juice cups are 4 ounces. Our coffee cups are 6 ounces. Pay attention to that because you need to know it. You know, how big the cups are and how many ounces they hold. But in healthcare, we don't document in ounces, we document in mLs or cc's. So that means we have to do conversions. So this is how we convert. 1 ounce is worth 30 cc's. That's our conversion. So if we have something that's 1 ounce, that means it is 30 cc's. If it's 6 ounces, we're going to multiply the 6 by 30 and get 180 cc's. If it's 8 ounces, we would multiply 8 by 30 and get 240 cc's. Good? So on the test, you may have a conversion question. It may say, excuse me, your patient took in 12 ounces of soda. How many cc's did the patient take in this shift? So 12 times 3 is 360. At the end of the shift, we would then have to add up all of the measurements that we took, all of the cc's that they took in, and come up with a total for the shift. So that's just addition. So if you look at the bottom of the second column on page 106, you can see that there's 6 ounces of juice. How many mLs would that be? 6 times 3 is 18 and add a 0, so 180. 8 ounces of milk. 8 times 30. This one you can cheat because the carton gives you the mLs. Remember, prepackaged will always give you the mLs. So this gives you your mLs. So how many mLs? 240. Remember, cc's and mLs, same thing, different names. 12 ounces of coffee. 12 times 30. Anybody? 12 times 30? 360. So we have 180 cc's of juice, 240 cc's of milk, and 360 cc's. That's a lot of coffee, guys. 360 cc's of coffee. And at the end of the shift, we would add all of that together. So 180 plus 240 plus 360. Anybody know? 780. That would be the total fluid for the shift. So on the test, you will have a math question. Just one. It's either going to ask you to convert from ounces to cc's, or it'll ask you to add up the amount of cc's per shift. Okay? Good? Not too bad. Guys, this is page 106 that we were working on. All right, so if you go to page 132, let me show you something else real quick. This is medical abbreviations. Anything that has been highlighted in gray is something that you want to know for the state exam. Flashcards help here. But let me help demystify this for you because everybody gets all concerned about this. When you are trying to make sense of this, understand that it's not English. PRN is not English. It is abbreviated Latin. So that's why it doesn't make any sense in English. Some of them, however, are abbreviated English, like CNA, Certified Nursing Assistant. So that's abbreviated English. So some of these are going to make sense, some of them aren't. But let me give you an easy way to remember this. When we're talking about Latin, B stands for bi. How many wheels does a bicycle have? 2. B stands for bi, which means 2. So BID is 2 times a day. TID, T stands for tri. How many corners are on a triangle? 3. So TID is 3 times a day. Q stands for quad, which is 4. So using the same logic, it should be 4 times a day. Well, we no longer use QID because Q also means every. So when you use medical abbreviations in Latin, B stands for bi, which is twice a day. T stands for tri, which is 3 times a day. But Q is going to stand for every. So QD would be every day. QOD is every other day. QAM would be every, what's AM? Morning. Believe it or not, AM is not English. We think it's not. It's ante-meridian, which is before the middle, before noon. Noon is middle. PM is also Latin, post meridian or after middle, noon. So QAM is every morning, QPM every evening, and QHS is every bedtime or hour of sleep. Remember, it's abbreviated Latin, not English. Good? Questions? All right, let's go all the way down to about 3/4 of the way down. You can see it here. That first column, you'll see NPO. NPO means nothing by mouth. Do not try to make it make sense in English. It does not. NPO is nothing by mouth in Latin. Nothing by mouth. So let me tell you a story about somebody who faked it till they didn't make it. So this actually, true story from a teaching hospital, a nurse, we'll call her Kathy, worked in the cardiac cath lab, goes up to get a patient. And this is the story as it was relayed to me. Patient was NPO because he's getting ready to have a heart cath done. 5 a.m., Kathy goes up to get the patient, take him down to the cath lab, get him ready for his heart cath. Patient is sitting up in bed eating. Kathy says, "Why are you eating? You're about to have a heart cath. You're not supposed to be eating." And the patient says, "I don't know. The nurse brought this in, said I had to eat it before my procedure." So Kathy goes out and finds the nurse. "Why is the patient eating?" Nurse says, "I don't know. Patient should be NPO." Kathy said, "I know. Why is the patient eating?" I don't know. But there's a student taking care of that patient. Kathy goes and finds the nursing student. This is the conversation. Why is the patient eating? Because the patient's NPO. I know the patient's NPO. Why is the patient eating? Because the patient's NPO. I went and got the tray special myself. Kathy's like, what do you think NPO means? And I swear this is true. The student says, Nana's, pineapples, and oranges. Nanas. Not even a real word. Nanas. Apparently, this nursing student had failed to learn what NPO was in class. And instead of consulting Uncle Google, which would have at least put her on the right path, she tried to make sense of NPO in English, and that is what she came up with. Oh, it's a procedure. He probably needs to be cleaned out for the procedure. Fruit does that. That must be what it means. So, real world consequences here. Now our patient can't get his heart cath. We have a surgeon downstairs that is twiddling his thumbs, which does not make them happy. This one student, because instead of admitting that she did not know and seeking the correct information, made something up. This is not a fake it till you make it industry. True story. Nanas. Not even a word. Come on. If you have a medical abbreviation that you come up against in a clinical setting and you don't know what it means, ask. Don't assume. Don't create. Ask. Okay? You're not going to know everything. That's the biggest thing I need you to understand. When you leave here, you're not going to know everything. There's going to be things that come up in your workplace that you are not familiar with. So you need to have enough integrity to be able to admit and then learn. Don't fake it. I still can't. That story was given to me like 16 years ago. I use it every class because it's a great illustration of what happens when you try to fake something. Unbelievable. I just can't even imagine. I can't imagine being Kathy having to go back to the cath lab and tell the doc, hey, your first patient isn't going to be able to be here because he's eating nanas. I mean, how do you say that to a surgeon? And then you have to duck because they're going to throw something. Surgeons have horrible tempers. Horrible. All right. So here we go. When you are estimating food, there is a quarter scale documentation sheet you'll be using. It just basically you check off or write in 0, 25, 50, 75, or 100, quarter scale. But if you're going to be documenting intake and output where we're actually calculating something, that's going to be on a different sheet, and it would look like this, an intake and output sheet, where we're actually going to write in numbers. And I've got a whole lesson on intake and output on page 107 that you can take a look at on your own. Let me go ahead and show you this skill, and then we're going to get into Peri-Care. Peri-Care does not take me long to teach you. You already know everything you need to know. It's a washing skill, just like every other washing skill. But we do have to talk a little bit about the normal elimination function And we have to talk a little bit about infection control. So it won't take me long. You should have quite a bit of practice time in class today. Oops.
Hello?
Hi, Mr. Jones. My name is Patty. I'm your CNA today. Would you like a snack?
Yes, please.
Okay, I'm going to go wash my hands, get my supplies, and I'll be right back. Can I ask you to sit up straight for me, please?
Okay.
Thank you. Okay, Mr. Jones, let me get you a hand wipe so that you can wipe your hands. Would you like to take that? Thank you very much. Let me
Thank you.
dispose of this. Okay, can I offer you a clothing protector?
Yes, please.
I'll just place this on your chest. Okay, it looks like we have pudding. How does that sound?
Great.
Very good. Can I offer you a drink before we get started?
Please. Thank you.
You're welcome. Okay, are you ready?
Yes.
There you go. Do you have any plans for this afternoon?
No, I do not.
They're showing a movie on the big screen in the activity room. Would you like me to get more information on that for you?
Yes, please.
Okay. How does the pudding taste?
Delicious.
Very good. Ready for another?
Yes, please.
Okay. Can I offer you a drink? Would you like something to drink?
Yes, please.
All right. Ready for another bite?
Yes, please.
Ready for another bite?
I'm actually full.
Are you sure you wouldn't like just one more bite?
I'm okay, thank you.
Can I get you something else from the kitchen?
No, thank you.
Okay. Let me know if you get hungry later, and we'll get something to eat. We do have food available on the unit.
Thank you.
Going to take the napkin. There we go. I'll remove this clothing protector from you, and we're going to put this in dirty linen. I'm going to go take care of your tray. I'll be right back.
Okay, thank you.
Okay, I'm going to place the tray back on your table. Is there anything else I can get for you? A magazine, perhaps?
No, thank you.
Your call light is within reach. Please let me know if you should need anything. I'm going to go wash my hands and document.
Okay, thank you.
After washing my hands, I'm going to document the amount of food that this patient ate. Using my documentation form. I'll review the steps of my skill, make any corrections, and tell the evaluator my skill is done. Yeah, I know a few of you have to leave. You got some personal things to attend to, and that's fine. All right. So any questions on feeding? Any questions on feeding? No? Okay. Let's move on to Peri-Care. This is going to be on page 152. Again, we have absolutely nothing new to learn here. No principles to master. We've already mastered all of them. Let's take a look at the care plan. Care plan says the female resident has been incontinent of urine and needs perineal care. The pad under the resident is wet, but the hospital gown and the bedding is dry. It is a miracle. It will never happen that way in real life. but we're going to take the testing miracle they give us. This is a mannequin skill. You'll be doing this on the mannequin, and the pad will not actually be wet. There will be a pad there, but it won't actually be wet. Okay. So a lot of supplies for this one. You got to learn them. But this really is just, it boils down to just a washing skill. We're going to do our opening. We're going to wash our hands. We're going to get our barrier. We're going to get our supplies. You will need gloves for this because we're in a personal area and there are body fluids. So we'll use some gloves. Privacy blanket is going to be important. Think about where we're washing. Our linen rules are going to play a part into this. You know, don't hold them against your uniform. Don't snap or shake them. We're going to turn our patient over at some point to wash their backside. So scoot and roll is going to come into this. Of course, washing rules and basin cleaning are a part of it. And then our closing. So there's not a whole lot that you're going to have to learn for this. We're just going to reuse all of these principles to learn how to do this. We will use the leaves method for this particular skill. Let's talk a little bit about a normal elimination system. So again, 5th grade review, guys. You've got 2 kidneys. Those kidneys filter blood and they produce urine. And this happens 24 hours a day, never stops. As those kidneys filter blood and produce drips of urine, those drips go down tubes called ureters and collect in the bladder. You got this little valve at the bottom of the bladder that holds it closed. Kind of like a zip on a Ziploc bag, right? Holds it closed so that the urine stays in the bladder until the bladder gets full. When the bladder gets full, it rings a little bell in the brain. Hey, we're full. Your brain goes, finds you a bathroom. You go in, the valve opens, the urine comes out, valve closes, and you're good to go for another couple hours. This system works the same on everybody, male and female. There is no difference in this system. The only thing that's different is the length of the urethra. So the urethra is the tube that the urine comes out of. In women, it's only about as long as your pinky. That's not very long. That's like a day trip for bacteria. With men, it has to go through the entire penile tissue, so it is significantly longer. That's why women are more prone to urinary tract infections than men, because with men, there's much more tissue to go through to get to the bladder. And our white blood cells tend to hang out in that area, and they tend to get rid of the bacteria before it invades. Women, shorter urethra, less white blood cells, more prone to infection. Good? So the way we wipe here is going to be very, very important. So when we are incontinent, the system still works. Kidneys still filter blood. They still produce urine. Urine still drips, drips, drips down your ureters, and it goes into the bladder. The problem here, the part that's not working, is the valve. Because the valve is floppy and not working, all of those drips come out. So remember, your kidneys work 24 hours a day. Drip, drip, drip. If that valve isn't working, those drips are just going to come right out of the body. That means that your incontinent patient is going to be wet all the time. Drip, 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 drip. Good? If you've got somebody who is dry, 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 really, really wet, they're not incontinent. What they have is incompetent staff members aren't getting them to the bathroom. Okay, good? Makes sense? Okay, so when we're incontinent, what doesn't work? The valve. That's right. So incontinent patients will always be wet, but adult urine, not like baby urine at all. In fact, baby urine, we don't even call it urine. We call it something cute like tinkle. We have cute words. So adult urine, not like baby urine. Baby urine is very mild. And the reason for that is our urine, the acidity level of our urine is going to be determined by what we eat. So when we eat and drink acidic things and almost everything as adults, that we eat and drink is acidic. When we eat and drink acidic things, then that acid that's left over is going to be excreted through our urine. So our urine as adults are much more acidic. Babies, they're on breast milk and formula and rice cereal and bland. So your urine's very alkaline. You can put a diaper on a baby, put them to bed, wake up 8 hours later, and they've got skin on their tushes. No problem, because the urine is mild. You put an adult brief on an adult, leave them there for 8 hours, that's holding acid right up next to the skin. What do you think acid's going to do to the skin? Burn it, eat it. Yeah, absolutely. So when we have an incontinent patient, remember, incontinent is wet all the time. When we have an incontinent adult patient, you can't just put an adult brief on them and leave them. We are going to clean them every 2 hours around the clock. That means we're waking them up at 2 a.m. and 4 a.m. and 6 a.m. and 8 a.m. to clean them up. Don't do them any favors and let them sleep through the night, because when they wake up, they're going to have big skin problems. It's probably going to take us weeks to overcome. Good? Make sense? All right. So adult briefs, we don't call them diapers with adults, just like we don't call it bibs, right? So adult briefs, you'll also hear them called depends. Those are fine too, just not diapers. They have a problem. They hold in body heat. They block out light. So now we've got warm, dark, moist. What grows there? Yeah, all the bad guys. Absolutely. So when we put an adult brief on somebody, we have to understand we are creating the ideal breeding environment for pathogens. So if they're out of bed, an adult brief is good. It's indicated, because nobody wants to wet themselves in public. I mean, that's kind of embarrassing. So that's okay. We're still going to clean them and change them every 2 hours around the clock. We got to get that acid off the skin. But if they're in bed, there's a better way. If your patient is agreeable, we will leave them open to air while they're in bed. That means they're not wearing undergarments, they're on a pad, and they're open to air. That pad is going to pull that urine away from the skin, so we don't end up with that warm, dark, moist environment. We have light and air circulating, so we end up with fewer skin issues when our patients are open to air in bed. Not everybody's comfortable with this, and that's okay. Remember, we treat every patient as an individual. So if your patient is okay with it, they'll have fewer skin issues. Good? That's how this skill is going to start. Our patient is a mannequin open to air on a pad. But let's think about that pad for just a second, okay? That pad, remember room temperature about 75 degrees, right? Body heat is 98.6. And actually urine is a little hotter because it's up in our furnace area. So when urine comes out, it's about 100 to 101 degrees. So if we have 100-degree urine hitting 75-degree air, what do we know about room temperature? It always wins. So what's going to happen to that urine? Uh-huh. And that pad is now going to feel cold, wet, and a little slimy to your patient. If you were laying on that pad, what's the first thing you'd want done? Yeah, change the pad. Get me on a dry pad. This just feels icky. So the first step that we're going to take with Peri-Care is to change the pad. Well, we got a wet butt on a clean pad. So when we're done with the skill, we clean the front, we clean the back, and then we're going to change the pad out one more time. So we're leaving our patient for the next 2 hours with a clean butt on a dry pad. So this skill requires 2 chucks changes. Good? Questions? All of our washing rules apply. Nothing new to learn here, right? Basins are no soap zones. We're going to use a barrier to turn the water on. We'll feel it. It should feel warm. Your patient feels it. We're going to change the water if it gets cold or soapy. We're going to use our leaves method because it's a wet body opening. Whatever we wash, we rinse. Whatever we rinse, we dry. And because it's the genitals and anal area, we will use that leaves method again. Change the water if it gets cold or soapy. Keep our surface dry and no lotion. We're going to follow the care plan here. So for this skill, we're going to do our opening, knock, knock, knock. We're going to put a barrier on the table and supplies on the barrier. We'll fill our basin, have them check it, put a privacy blanket on, and apply our gloves. Remember, the first thing your gloves should touch is the patient. And the first thing we want to do is change that chucks out. Now remember, clean rolls toward me, dirty rolls. We're going to use it here too. Remember, nothing new to learn here. Nothing new to learn. We're going to roll the blanket and the gown together and place the towel over the legs. So let me show you what I mean by that. So can I get you to just sit right back there for me? I think, I don't know, Lucy, I may have to have you move as well. Oh, you know what? Hold on. I may be able to do this. Hold on. Does it work? Yes. Okay. You can go back to your seat. All right. So I don't have a privacy blanket here, but let me just use a towel to show you if this was a privacy blanket. Okay. So we're going to put a privacy blanket over the patient and we're going to pull the sheet down to about their knees. Okay. When I'm going to do Peri-Care. Now, I've still got to expose her to do Peri-Care, but I only want to expose her a little bit. I want to minimize exposure. So to do that, I'm going to take the privacy blanket and I'm going to roll the gown underneath like this. And that exposes the area I'm going to work on. And then I'm going to take a new towel and place it over her legs. Do you see how this really minimizes exposure? Your patient will be much more comfortable with this. This is completely different than that. Which one would you be comfortable with? Yeah, nobody's comfortable with this. Everybody's like, cover her back up. That is just not cool. So when we do this, we roll the gown inside the privacy blanket. And I'll explain why in a minute. And then we put a towel over the legs. We do our cleaning. And now when we're ready to pull that gown down, remember, I've done my cleaning. My gloves are not clean. I don't really want to touch that gown that's going to stay on her. So by doing this, I can unroll that gown without having to touch it. Make sense? Good? Okay. So minimizing exposure becomes very important. Minimize exposure. So do you guys understand why we roll the towel underneath? Or I'm sorry, the blanket underneath with the gown? And then we'll put a towel over their legs just to only expose the area we're working on. We'll wring those washcloths out thoroughly. Oops. Let me go back here. We'll wring those washcloths out thoroughly so we don't have drippy, wet washcloths. And we're going to clean the peri area from top to bottom. So we're going to use that leaves method again. I have my washcloth here. For those of you who don't remember, we have a plain square washcloth folded in half and in half again, but I'm going to hold it as a diamond and tuck the two side pieces in. Now, I've got this area to clean with. When I'm going to clean the peri area, I need to hold her open just a little bit so I can get down the inside middle. So if I'm holding my washcloth, I'm going to hold her open and go top to bottom. Once I get to the bottom, I'm going to pull away. Never go back up. This is where all of our E. coli lives, and we don't want to bring it up to the urethra. Remember, urethra is only as long as your pinky. So hold open, top to bottom, and then we're going to fold that over. The second stroke will be on the outside, so I don't have to hold her open. Outside, top to bottom, fold that over, and the other outside, top to bottom, fold that over. Now this area where the leg and the groin meet, that little crease or skin fold, we're going to go down that crease, fold this over, and down that crease. Whatever we wash, the exact same way. Same method. And then whatever we rinse, we dry. So we're going to pat dry top to bottom. Okay? Good? Remember that we never move back up. It's a one-way trip, and that's what they're looking for here. One way only. So whatever we wash, we rinse the exact same way, and whatever we rinse, we dry. Then we'll remove the towel, cover the patient with a blanket. We're going to scoot them toward us to turn them on their side so we can clean their backside. Because remember, they're laying on that wet pad. Their butt is all wet with urine. So once I get them on their side, I'm going to take a washcloth, spray my corners, and I'm going to start at the anal opening and go up the center crease. Never back down. Start at the opening, up the center crease. We'll fold that over. We're going to clean one cheek, fold that over, clean the other cheek, fold that over, and once more up the middle crease. And then whatever we wash, we rinse the exact same way, and then we dry. Okay. Good. Questions? Now we're going to change the pad again. Clean rolls toward me, dirty rolls away. Like I said, there's nothing new to learn here. You know everything you need to do this skill. So not much there. We'll return the patient to the center of the bed. You want to make sure that they're always in the center of the bed, and then we'll go clean all of our equipment, put our dirty stuff away. And once we've got everything cleaned up, we can remove our gloves and remove the privacy blanket. You want to remove the privacy blanket after you remove your gloves, because remember, you don't want to touch that sheet that's going to go right up next to their face with those gloves. Do your closing, and that is it. So let me show you the skill, and then you'll have some time to practice. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Wonderful. I need to do Peri-Care. Is that okay? Okay, let me close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, I'm going to start out with a barrier. This gives me a clean place to place my clean supplies. So I'll place the barrier on the overbed table. And now I'll start gathering my supplies. I'm going to need 2 chucks, 4 washcloths, a privacy blanket, a towel. I'll place these items on the overbed table. I'll need a basin and soap. And I'm going to need a set of gloves. Okay, Miss Jones, let me go fill the basin. I'll use a paper towel to turn the water on. I'll make sure it's warm, not hot, not cold, just warm. Miss Jones, would you like to check the water temperature and make sure it's okay? It's good? Good. I'll place my washcloths in the water. Okay, Miss Jones, I'm going to place this privacy blanket over you. This is going to help keep you warm and protect your privacy while we do this skill. I'm going to spread the blanket out, being careful not to shake it or snap it. And then I'm going to pull your sheet down to about your knees. Now I'll get my chucks ready for use. I'm going to unfold the chucks, hold it up lengthwise, and roll it toward me. And I'll repeat that with the second one. Clean rolls toward me, dirty rolls away. Now I'll get my gloves on. Okay, Miss Jones, in just a moment, I'm going to ask you to scoot toward me, and we're going to roll you onto your left side so I can change the chucks that's under you. I'll place one of the chucks on the bed. Miss Jones, can you scoot toward me, please? Thank you. And roll up on your left side. 1, 2, 3. I'm going to roll the dirty chucks toward the patient. Tuck it under her hip. Unroll the clean one and tuck it under the soiled. Miss Jones, can you roll back onto your back, please? Thank you. And scoot to the middle of the bed. Okay, I'll come around to the other side of the bed now. Miss Jones, can you scoot toward me, please? And roll up on your right side. 1, 2, 3. We'll remove the soiled chucks from the bed and unroll the clean one. This is going to be thrown away. Okay, Miss Jones, we're going to start cleaning now. I'm going to roll your blanket up to about your waist. This is going to expose you. Please let me know if you're uncomfortable in any way. So I'll roll the blanket up, and on the way I'm going to try to get that gown rolled inside the blanket so that exposes only the peri area. I'll cover her upper legs with a towel, and then get my first washcloth. I'm going to wring this out and soak 5 corners. 1, 2, 3, 4, 5. Okay, Miss Jones, I'm going to clean now. I'll use the heel of my hand at the top of her peri area and my index and middle finger to spread her slightly open so I can clean down the inside middle, top to bottom, and then we'll fold that leaf over. We're going to clean the outside labia, top to bottom, down one side, and fold that over. The third leaf will clean the other side of the labia, top to bottom, fold that leaf over. The fourth leaf is going to clean this area between the leg and the groin, this skin fold, top to bottom. We're going to fold that over, and we'll repeat it on this side, top to bottom. Now we'll place the washcloth back on the barrier. The second washcloth we're going to wring out, and we're going to rinse all of those areas the same way we washed. So we're going to hold her slightly open to clean down the middle, top to bottom. Fold that over. We're going to rinse down one side of the labia, top to bottom. Fold that over. Rinse the other side of the labia, top to bottom. Fold that over. We're going to rinse the skin fold down one side, top to bottom. Fold that over. And the other skin fold, top to bottom. We'll set that aside. Now we're going to dry all of those areas using short, soft strokes or a gentle pat. I'm going to unroll the blanket, which will place her gown back over her legs. Okay, Mrs. Jones, I'm going to scoot you toward me now, and we're going to roll you onto your left side so I can clean your back side. Go ahead and scoot toward me, and we're going to roll you over onto your left side. 1, 2, 3. The evaluator will hold the mannequin in place for you to complete your cleaning of the patient's backside. Okay, I'm going to take the fourth washcloth, wring it out really well, and we're going to soap 4 corners. 1, 2, 3, 4. I'm going to start at the anal opening and go up the center crease, right up the middle, and we'll fold that leaf over. The second leaf will clean 1 buttocks. We're going to fold that over. The third leaf will clean the other side of the buttocks. We'll fold that leaf over. And the fourth leaf will clean from the anal opening up the center crease one last time. We're going to set that aside. Whatever we wash, we rinse. So I'll wring that out. And I'm going to rinse the same way we washed. So from the anal opening up the center crease, fold that over. 1 buttocks, fold that over. The other side of the buttocks, fold that over. And once more up the center crease. And then we'll dry all of those areas. Okay, Ms. Jones, I'm going to change that pad out from under you so you're on a nice clean pad. We'll roll the soiled chucks toward the patient and tuck it under her hip. Unroll the clean chucks and tuck it under the soiled. Ms. Jones, come on back, please. And scoot to the middle. Thank you. Okay, Ms. Jones, go ahead and scoot toward me. And roll up on your right side. 1, 2, 3. Thank you. We'll remove the soiled chucks from the bed and unroll the clean. Okay. Go ahead and scoot back to the middle, please. This is going to be thrown away. Okay, Ms. Jones, I need to put all of my soiled items away and clean my basin. I'll be back in just a moment to get you situated. These items will go in dirty linen. And the basin is going to be cleaned the same way we clean everything else. We'll dump the water into the sink. Rinse the basin. Pick it up with a paper towel and dry the inside. We'll discard that paper towel. We'll dry the outside and discard that paper towel. And then we'll get the soap. I'll use the paper towel to open the drawer and store the basin back inside. These paper towels will now be thrown away. The barrier is going to be disposed of. And now I can remove my gloves. Okay, Ms. Jones, I'm now going to gather the privacy blanket up and pull your sheet back up. So I'll collect the privacy blanket by lifting from the bottom or underside of the blanket. I'm going to pull the sheet up and ball the blanket up into a ball. That way no trailing edges will contaminate other surfaces. Okay, Ms. Jones, let me go put this in dirty linen. Are you comfortable? Is there anything else I can get for you while I'm here, like a magazine? Okay, here's your call light. If you should need anything at all, please let me know. I'm going to go open your curtain and wash my hands. After washing my hands, I'll think about the steps of my skill, make any corrections, and then let the evaluator know my skill is done.
All right, any questions? All right, homework tonight is chapters 8 and 9 over the weekend. 8 is on rehabilitation, adaptive devices, that type of thing. 8 is on nutrition. 9 is on rehabilitation. So nutrition, it's not a long chapter. It's not really overly complex. Nutrition is way more complex than the chapter makes it out to be. This is just a high-level overview, but it is going to get into different diets. You don't need to know what condition needs what diet. What you do need to know is a little bit about the what happens if you give the patient the wrong diet. Okay,
why it's so important to stick to the diets that are ordered. Okay, good. You're almost done with homework. After this, you only have one chapter, chapter 10, and that's super short and really easy. So you're on the downhill slide now. It gets easier from this point. 2 classes left. That's it. So you're making really, really good progress. CPR will be next Monday. It's the last chance for you to get it for $45. So if you need CPR, make sure that you're here next Monday. It'll be from 2 to 6. So class will be till 1. You'll have a break to be able to get lunch. And then 2 to 6, we'll be doing CPR, BLS. Minette says, I would like to do some practice tests. Are the tests on the CNA site too? Yeah, Minette, if you go on to flcnatraining.com, I actually have a link on there for the practice test. I think it's on class 7 or 8. So you can check that out. Anna says, does the evaluator want us to describe everything we are doing during Peri-Care? Yeah, you really should, but it's not so much for the evaluator, it's for the patient. You're in their personal space. They need to know where you're going and what you're doing. So talking this out, imagine how, those of you who have had exams, imagine how unnerving it would be if the person doing a very personal exam was completely quiet the whole time. There's a reason they're talking to you, and it's to make you comfortable. So when we're doing Peri-Care, yeah, you probably do need to talk it out. Let them know, okay, I'm cleaning the inside, cleaning the outside. Now I'm going to rinse. Now I'm going to dry. When you talk it out, it helps the patient. It'll help the evaluator too, because they may not see every step that you're doing. So it will help with your score, but I really want you to do it more for the patient. Good. Any other questions? Review sheet. I've already handed out the review sheet for the class. For those of you online, the review sheet can be found on flcnatraining.com. We give those away for free too. So any questions on what we've gone over? You guys have only got 3 skills left. We've got our last range of motion. We know how quick those are. We've got catheter care, which is a variation of Peri-Care. And you've got emptying the urinary drainage bag. That's it. It'll only take me about an hour and a half of teaching on Monday. The rest of the time will be practice. So lots of practice built in.
I have a question. For the CPR, I have it with my job already. Do I have to have the money?
You don't have to have CPR for the class. You don't need it for the test. You will need it to work. So if you don't have CPR, you will need it to get a job in healthcare. You don't have to get it through me. You can get it through anybody. We just happen to offer it twice during your class at a reduced rate for you. Okay. All right. The rest of the class is practice, and I'm going to go ahead and sign off for our virtual students. Thank you guys so much for joining us. And we will be back on Monday for week 4. This class is almost done. The next class will start June 10th. I have a couple weeks off in between classes. So thank you guys for joining. Hope you can tune in on Monday. Tuesday is the game show. Don't forget that too. Mark your calendars. Tuesday is the game show. So until next time, guys, happy caregiving. Bye.